testing 1, 2, 3. Testing 1, 2, 3. Testing 1, 2, 3.
Can we get everyone sitting down so we can get started? All right, good morning. Thanks for joining us today in this first Liver Connect meeting. I'm Zubair Nasi. I think I know all of you. So again, it's really a pleasure to be in this wonderful, beautiful result. And actually, the Arizona weather has cooperated well. What I just want to do is to just spend a couple of minutes about explaining what Liver Connect is. This is going to be an annual meeting starting this year. And it's a platform that's being implemented by Chronic Liver Disease Foundation to really bring clinical practice, academia, and industry. The main session, which is going to start tomorrow, is really preceded by summits. So today is the International NASH Summit. We will have other summits in the future. The meeting is actually being designed as a hybrid meeting. In fact, today's meeting is mostly virtual. We have 220 people who've signed up for the main meeting. Our capacity was only 200, so we had to close registration yesterday. For the virtual side, we have 550 people that are actually, for today, that they're logging in. So that's part of why I'm actually starting the meeting on time. The next, of course, intention here is to bring in collaborations across the globe, not only from different countries people are signing in, but also from different specialities. We have endocrinologists. In fact, Dr. Isaacs, who's actually from endocrinology from ACE, is here, and we'll have also primary care. Our advanced practitioners all actually participating in some fashion, as well as gastroenterologists and hepatologists. And hopefully in the future, we'll have more and more primary care and cardiologists involved as well. We also invited all the International Coalition of Hepatology Education Partners that used to be an entity of its own, but it's now part of Chronic Disease Foundation. The meeting also will have an opportunity for the industry and our committees, NASH committees of CLDF, as well as other committees, to exchange ideas and collaboration. So hopefully you'll enjoy today, and we'll start with the first program, which is the NASH Summit, and this is the agenda. You see that some of the leaders in NASH are actually members of the faculty. Now, unfortunately, we could not have anyone from outside the United States this year because of COVID restrictions, but this is going to change with next year. The venue is actually set up with CDC's guidance, with social distancing, although I think most people in this room are vaccinated also. The meeting tomorrow is going to start at 8 a.m. Actually, it's at 7 a.m. with a pre-meeting AbbVie-sponsored program that Dr. Mensch is going to present around hepatitis C. And then we will have a keynote speaker that you all know, Harvey Alter, who's a friend and, of course, is a Nobel laureate for 2020. We have about 5 different sessions for tomorrow, including a session on both alcoholic and non-alcoholic fatty liver disease, as well as other areas of viral hepatitis and also complication of cirrhosis. So with that, I'm going to go ahead and actually get started with the first part of this meeting. And my task here was to give you an update of why do we care about non-alcoholic steatohepatitis, and give you an update about burden. Some of the data that I'll show you is actually quite recent, but some of it that you probably have seen in the past. But just go quickly over some of data that you may already know. The prevalence of NAFLD, as you all know, globally is about 25%, with the highest prevalence being in Middle East and also in South America. Now that's important because of some other data that is from GBD, Global Burden of Disease, that I'll share with you in a few minutes. The prevalence in type 2 diabetics is at least 55%. This is global meta-analysis. Again, very high prevalence in Europe, as well as Middle East and South America. In kids, the prevalence is about 8% or so. Again, very high prevalence in children from South America. When you look at the type 2 diabetics, the prevalence of non-alcoholic steatohepatitis, which is the progressive type of NAFLD, is about 37%. In general population, we estimate the prevalence of NASH is about 1.5 to 6.5%. Let me just show you some data from NHANES for adolescent and young adults. This is data between 2007 and 2016. Almost 4,500, over 4,500 subjects were actually included. NAFLD was actually defined by USFLI and also exclusion of other causes of liver disease. When you look at the overall prevalence of NAFLD in this group, it's about 18.5%. Starts with about 13% or so in the younger population and goes up to about 24% in the older group of young adults. Similar to what you've actually seen from sort of tertiary care center data, the prevalence is actually higher in boys, and also the prevalence is higher in Hispanics or in the United States. When you look at the prevalence over time, the overall, this is for age 18 to 24, at least for this group, there is an increase in the prevalence. You've also seen some version of this slide about clinical outcomes of NAFLD. And I would really think about outcomes into sort of three different aspects: clinical outcomes, patient-reported outcomes, and economic outcomes. In clinical outcome, the most common cause of mortality in patients with NAFLD is cardiovascular mortality. However, patients with NASH subtype, predominantly the NASH subtype, develop cirrhosis and liver cancer, and of course at risk for complications of cirrhosis, including liver-related mortality. Now, there are two peculiar things about this disease. One, of course, is that you can develop liver HCC in the absence of cirrhosis, which is really only seen in other liver disease, which would be hepatitis B in general. The other peculiarity about this disease is that this is not a linear progression of this disease. You can have progression and regression. Of course, this would lead to a high placebo rate. Mario Ranella has published something or presented something about this, that the placebo rate could be about 20% or even 30% for some of these patients. So it's really important to understand that the progression of this disease is pretty complicated. This is some of the data. Let me just go back one slide. Some of the data showing that the prevalence of NAFLD in the United States is going up while the prevalence of hepatitis C is declining. NAFLD is among the top 3 causes of liver cancer in the United States. And this is also important, as I can show you, the rate is actually also increasing in the recent years. And it's already the second indication for liver transplantation in the United States. Of course, the first indication is alcoholic liver disease. And as you can see in the red line, hepatitis C indication for liver transplantation is actually also declining. This is data, mortality data from NVSS, which is basically death records in the United States for 2017 to over time from 2007 to 2016. And as you can see, actually both alcoholic and non-alcoholic fatty liver disease is going up in terms of causes of death. And that was recorded in the NVSS. When you look at hepatitis C, it's declining. And when we look at hepatitis B, it's actually stable. When you look at 2017 data from the same source, you'll see that the prevalence is actually going up, or the cause of death related NAFLD is going up in both men and women, but the rate of increase is actually higher in women than men. The other important point of this study is that you see that when you look at the causes of death, the annual % change was highest for HCC than cirrhosis. So HCC is also, as you all know, worldwide is becoming a major complication of non-alcoholic fatty liver disease. Modeling, a number of versions of these modeling you've seen. This is Homi Razavi's group, published this a few years ago, showing that over about 15 years, there is a doubling of the advanced form of NASH. Complications of NASH-related cirrhosis is increasing. 800,000 additional deaths in the United States was expected by 2030, and the same data or similar data was replicated in the rest of the world. Couple of studies on GBD, which is Global Burden of Disease study, that I want to share with you. This is actually related to mortality of different liver diseases. 4 common liver diseases: hepatitis B, hepatitis C, alcoholic liver disease, and non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis, in fact, in this case. And different regions are actually in the rows that you can see. When you go back and look at the boxes, if the boxes are red, that means that the percentage, the annual percentage change is positive, or there's an increase in mortality. And when you look at the column that represent NAFLD, it's the only one that has a lot of red, meaning that mortality from NAFLD is increasing across the world between 2012 and 2017. Another study looking at DALIs, which is basically looking at mortality and also quality morbidity combined, that's disability associated years of life, and again looking during the same period of time, 10 years, 2007, 2017. Again, if you look at the column that represents NAFLD, DALIs are increasing in most regions of the world. Now, I mentioned that the issue is important for children because this is basically the tsunami that we can expect in the future. This is actually a GBD data that we presented recently about children. And you can see that in 2019, for kids that were between 15 and 29, about 11.3% of incident cases of cirrhosis and about a third of mortality was related, of cirrhosis-related mortality was in this age group. Of course, as you would expect, because of the burden of viral hepatitis across the world, hepatitis B and C are the 2 most common cause of cirrhosis and cirrhosis mortality. Alcoholic liver disease was about 8%, and NAFLD was about 4%. And what is actually, again, important is that when you look at the rate of rise between 2009 to 2019, it's really NAFLD that's actually in the group, both in terms of incidence, but especially in terms of cirrhosis deaths, especially in the age group of in sort of their mid-20s, that's actually going up, that's increasing. So that tsunami is expected to increase over time. Another study looking at GBD is the burden of disease in the Middle East and North Africa and Asia. There's again another study that we looked at. And when you can look at the entire burden of NAFLD-related mortality and morbidity, about 40% of it is actually occurring in this region of MENA and Asia. When you look at the changes over time in terms of incidence, there is incidence of complication of liver disease, cirrhosis, and liver cancer. Almost every region in Asia and MENA is actually increasing. When you look at mortality, same thing. When you look at what actually is associated with what predicts this increase both in incidence and mortality is metabolic risk factors. It's as well as dietary risk factors. In Middle East, in addition to those 2 risk factors, low activity were associated with an increase in mortality. Now, the second type of clinical outcome is extrahepatic outcomes, and you've seen a lot of these in the top 3 that I just want to mention is cardiovascular. I already mentioned that. That's the most common cause of death. Non-hepatic cancers are very common and are becoming one of the important extrahepatic manifestations. Sarcopenia is the one that I will also mention. So this is, again, a study we published recently from using an Haynes data set and categorized patients based on NAFLD patients based on having the old Framingham score, of course, ASCVD, at high risk and low risk. And when you have NAFLD and you have high risk Framingham score, both cardiac mortality and overall mortality is higher. Sarcopenia is another study looking again at enhance. Sarcopenia is actually defined as a standard fashion here. You can see that in both NAFLD and non-NAFLD patients, sarcopenia is associated with low activity. On the other hand, in NAFLD patients, sarcopenia is independently associated with overall mortality and actually cardiovascular mortality, even cancer mortality. So that suggests that this type of complication, the sarcopenia complication of NAFLD, needs to be actually looked at very carefully. The second type of outcome is the PROs. About 40% of patients, this is from the global NASH registry data that some of you are actually members of. About 40% of NAFLD have symptoms of fatigue. Quality of life is impaired, and multiple studies have been published on that, and impairment becomes even worse when you have more advanced fibrosis. The last type of outcome is economic outcome, economic burden of non-alcoholic fatty liver disease. This is just US data, that the indirect cost of NAFLD is really not known, but the direct cost or direct sort of lifetime direct cost of NASH, advanced NASH here was about $100 billion for the US. Now, the conundrum is that the burden is high and it's increasing in all age groups. However, the awareness about this disease is quite low. This is again from enhanced data. And when you look at patients with NASH versus those who have viral hepatitis, about 37% of patients with viral hepatitis knew that they had liver disease. And only about 4% or so of patients with NASH knew that they had liver disease. You'll see a more detailed slide later on in one of the other talks about health system level. This is from VA data showing that when you actually even have documentation of patients who would have been, should have been diagnosed with NASH, very few patients. In fact, 10% was diagnosed, and those that had even risk for more advanced fibrosis in NASH, only 3% were actually referred to subspecialists. And finally, this is at provider level. This was presented last year. This is a global survey of NASH or knowledge about NASH from providers, primary care physicians, endocrinologists, gastroenterologists, and hepatologists from 40 different countries. And as you can see, the knowledge about NASH is actually low, especially among primary care physicians, which actually are the gatekeepers for this disease. Do we have any predictors of who's going to actually have bad outcome? Well, clinical predictors are probably metabolic conditions, type 2 diabetes being the most important one. I would also probably suggest that visceral obesity is another predictor of adverse outcome. This is a study we published many years ago looking at the outcome of advanced fibrosis. Independent predictor was not only having type 2 diabetes, but also male gender and a few other laboratory tests. Mortality as an outcome, this is again from enhanced data that we have published. And if you look at mortality, increasing number of metabolic components of metabolic syndrome will increase the risk of mortality. So having components of metabolic syndrome, specifically those that are related with insulin resistance, visceral obesity, and type 2 diabetes, are independent predictors of mortality. How about histologic stage of fibrosis? This is actually the most recent meta-analysis that was published last year in gastroenterology. And we have actually published before, as well as Rohit's team had done another meta-analysis a few years ago. When you get to about stage 2 or higher, that's actually that stage of fibrosis is an independent predictor of both overall mortality as well as liver-related mortality. Why is that important as a surrogate stage of fibrosis? Well, this is a study that Arun Sanyal presented at the last liver meeting, showing that for patients with advanced fibrosis, if actually fibrosis regressed, the liver complication events were actually lower. So this is really the reason why most of the clinical trials are focused, at least partly, in regression of fibrosis. Now, in addition to clinical outcome, you can also see that some of the NITs are associated with actually adverse outcomes. This is actually a study we published in Gastroenterology last year, looking at the STELLAR 3 and 4 data. Patients, of course, with advanced fibrosis, their clinical outcome was worst, but also looking at PROs, their PROs was also worst when you had more advanced fibrosis as determined by NITs, ELF score, NAFLD fibrosis score, and even transient elastography. In fact, when NITs improved, some of these PROs improved. So to summarize, NAFLD affects about a quarter of the world population. You all know that really the NASH subtype, which is actually only can be made by a liver biopsy or histologically, is the predominantly progressive form of NAFLD. Now you can have a patient with non-NASH NAFLD that can progress, but in general, it's the NASH subtype that can progress. And it's important to remember that we're not talking about just a liver disease, that we're talking about a multi-systemic disease. That's why we have the team of endocrinologists, primary care physicians, and others to actually work with us and with us, a multidisciplinary team to take care of these patients. It's important, of course, to always focus on clinical outcomes of mortality, and surrogate for that being stage of fibrosis or presence of type 2 diabetes. But it's, from my perspective, it's also incredibly important to include patient-reported outcome, which is a surrogate for patient experience, and also economic burden of non-alcoholic fatty liver disease. The global burden of NAFLD, as I've shared with you, is high and increasing. And for that reason, it's really important that we actually develop policies that are not only national, but also global. There are a number of efforts going on, both in the United States, as well as globally through WHO, and also through the EASL Foundation, to actually bring policies across the globe to deal with NAFLD as one other important non-communicable disease that needs to be on the agenda for WHO and others to address. So with that, I think I'm right on time. I'm going to stop, and thank you very much thank you. I don't have an agenda. I think the next presentation is with Professor Mazen Nuruddin, who is doesn't need introduction. Dr. Nuruddin is a professor of hepatology and chief of fatty liver clinic at Cedars-Sinai. He has been really a pioneer in the area of a lot of areas of NASH, but specifically around NITs. And what we're hoping to do is to have Mazen give us an idea about how to use NITs in clinical practice. Mazen, welcome.
Thank you, Zubair. You gave me too much credit. I'm still an associate. Oh my God, I'm in a podium. I love you, everyone. Good seeing everyone. I would like to thank those that they're wearing a suit today. So I'd like to thank the organizers for inviting me to talk about NASH screening and diagnosis in primary care and endocrinology practice setting, the role of non-invasive testing. Let me see how I advance. It's kind of starting all over. So those are my disclosure. Another disclosure, this is my first talk in a year, and I'm wearing a suit. I woke up this morning, I found a sticker on my jacket. It says, I'm sure you're gonna wear your jacket, but please switch your pants from the pajama to regular pants. So that was from my wife. So the glass is not quite half full yet. So in ideal world, you would wish what we're doing in endocrine and primary care clinic, it's what our hepatoendocrinologist is doing, Ken Kusi. But our hepatoendocrinologist, it's not what's happening in the real world. We have tired people, fatigue, overworked, and they're seeing a lot of patients. So I don't need to tell this group about NIT a lot. I'm gonna talk more tomorrow, and Rohit is gonna follow with that. But I think we need to understand what's happening in the world. I think we need to go to their shoes, simplify the message, tell them what to do, understand what's going in their mind, because we're really seeing the ice of the tip of the iceberg. So how we can improve that, especially when we're going to have treatments, things will change. So Zubair just showed this. This is his data. And it's just a reminder, this is 25% of the population. We're not seeing that. We're seeing much less than that. And a lot of patients are screen failing in clinical trials with the ballooning on biopsy excluding them. But once we have treatments, these patients, they're gonna come. And I don't need to tell you the prevalence in type 2 diabetes is almost 50%. On the right side of this slide is the cost in the system and the trillions and billions of dollars that's costing our system. So there's no question that we need to do more and save our system money and help our patients. So let's look at things. You might think that in primary care, the prevalence is 25%, but it's not. We know in bariatric clinic, the prevalence is 70 to 90%. In hepatology, it's about half of the patients. Diabetics clinic, it's about half of the patients. But primary care clinic, it's not like the general population. Why? Because they see the type 2 diabetic patients, their clinics are overflooded with those, and we have 34 million type 2 diabetes patients and 88 million with pre-type 2 diabetes. They see the hypertension, dyslipidemic patients, and the obese patients. So you will expect that the prevalence of NAFLs is north of the 25%. So they see way more than 25%. NASH in the general population at most 6.5%. And with enrichment of risk factors in primary care, you will expect NASH to be more. Let's go back to their burden, because we really have to negotiate and understand what's going on in their clinic. So primary care, on average, 40% of them, they see 11 to 20 patients a day. 30% of them, they see 20 to 30% a day. So that's 70% of primary care, they see 11 to 30 patients a day. That's a lot of patients. Now you're gonna go to their clinics and tell them, hey, there's another disease that you need to screen for and do. There's FIB4, ProC3, FibroScan, MRE, and this and that. We cannot deliver the message that way. Also, a study just published in JAMA Internal Medicine looked at the use of EMR in different settings. So the primary care specialists use EMR on average 115 minutes a day. I think it's a little bit north of that. We as a specialist, we use it about 85 minutes on average daily. The surgeons do .OR and they do 45 minutes, half of that. So they also have a burden of using EMR, and we're talking about using EMR to increase awareness in their clinics. So all these things needs to be taken in consideration when we negotiate with them or educate them and increase awareness. Let's see how they thought about NAFLD, and there are not too many studies. So this is a study across the Atlantic from England that 1,000 patients were referred to from primary care to specialists because of elevated liver enzymes. Quarter of them, they had NAFLD, and a quarter had alcoholic liver disease. And they looked who had advanced fibrosis through NAFLD fibrosis score, and the prevalence of advanced fibrosis was 7.6. Well, luckily, 58% did not have advanced fibrosis. So let's just look at the pattern of elevated liver enzymes. Well, first, let's look why liver enzymes were checked. It was all over the map: diabetes review, non-specific blood test, hypertensive disease. So they were checking them randomly. And then the pattern of liver enzymes were, as we expect, GGT was the most prevalent elevated liver enzymes, and usually our primary care doc here, they don't check that. ALT was about average, 40% or so elevation. ALT 40% or so. AST is less. Look at the right again. This is important. 7.6% had advanced fibrosis, but also the indeterminate is very important. So lump the indeterminate plus the advanced fibrosis together, and you have about 45% people need attention. And of course, they're not paying attention to them in primary care setting. So that's important. Those are the people that one day can show up in our door with cirrhosis. Coming back to the US. So this is a study from Hashim and Siraj groups in the VA. What they did, they took 20,000 patients from the VA, and they said, let's look at 2 liver enzymes elevation more than 40. So those are 20,000 patients with 2 ALT more than 40, and then they took a sample of 450, and then identified NAFLD as following: metabolic syndrome, overweight, no Hep B, no Hep C, and then they studied this smaller sample. So let's look at the 250 they identified as NAFLD. Well, although they had elevated liver enzymes, they were only 40% of the time mentioning that their enzymes were elevated. They talked about NASH only 20% of the time. Referral to hepatologist was only 10% of the time. Well, the alarming part is at the bottom. Those with advanced fibrosis, which was about 15%, they mentioned their elevated liver enzymes in the chart 30% of the time. They referred to hepatologist or GI 3% of the time, and they mentioned NASH only 17% of the time. So these people are sitting in their GI clinic with elevated liver enzymes, with advanced fibrosis, and they are not paying attention to them. And they looked for triggers for referral. It was ALT more than 80, the most triggering factor, followed by ALT more than 40 on 2 occasions. NAFLD fibrosis score was not a trigger. So all these factors are very important, and we need to pay attention to them. And let's take a look at how they think. So this is a survey study. The good news is that 65% of them, they think that the prevalence of the disease is about 30%, 20-30%. That's good. But in orange, 30% of them, they think NAFLD is prevalent in only 10%. That's not good. Look at orange in the bottom. So those are the people that disagree. So 40% disagree that this is clinically important disease. So they think it's not important disease. 20%, they're not comfortable diagnosing it. They're not 30% not comfortable managing it, and 50%, they don't think we should refer to gastroenterologist and hepatologist. And let's look at those that refer to GI versus in orange versus those that they don't refer to GI in gray. So those that they refer to GI, they think it's clinically important disease. And those that they don't refer to GI, they don't think it's clinically important disease. Yet those that they don't refer to GI and they don't think it's clinically important disease, they are comfortable managing it and they're comfortable diagnosing it, although they don't think it's an important disease. So that's a problem. And this is the last survey I'm showing comparing PCP to specialist. So the PCPs, they were not familiar with NAFLD and NASH, almost half of them. And there were 2 GI specialists, they were not familiar with NAFLD and NASH. I would like to know who these 2 guys. And there were also, half of the primary care did not screen for NAFLD or NASH versus specialists. They did look for it and screen for it. Also, almost 40% of the PCPs did not know the difference between NAFLD and NASH. So this is important when it comes to NITs. When they ask them, if you don't have a liver biopsy and you want to diagnose NASH, what do you do? The PCPs said, well, it's liver enzymes and ultrasound, and the specialist checked that as well. But when you move down the list, they said, well, we can use other tests such as FibroScan, other tests, maybe that's FIB4 and NAFLD fibrosis score. And you see the PCPs in the bottom box, they mention none of those. So they're not aware of these tests. So we have a room here to educate them that, hey, those are existing. But how do we educate them? It's important to talk about guidelines. As I showed you earlier, they're overwhelmed. So they follow guidelines. They're good about that. And let me show you an example that exists out there. This is the ADA guidelines about type 2 diabetes. It's clear, simple, and easy and straightforward. There is recommendation to screen for type 2 diabetes. BMI more than 25 or more than 23 in Asians. And if they're age more than 45, you screen for type 2 diabetes. Then let's look at NAFLD, American College of Physicians, silence. They just talk about type 2 diabetes and its medications. American Academy of Family Physicians, silence. The good news is the American Diabetes Association, they started talking about NAFLD. They said medications that improve type 2 diabetes, they may improve non-alcoholic fatty liver disease. They also mentioned that this is the sentence: type 2 diabetes or prediabetes with elevated liver enzymes or steatosis on ultrasound should be evaluated for NASH or liver fibrosis. So it's kind of subtle language. They're not saying like you really should screen, but if you see it there, go after it. Look for NASH and look for liver fibrosis. This is the ongoing debate about the ASLD guidelines that Dr. Ranella is gonna work on hopefully soon. So the ASLD guideline did not recommend in the most guidance to screen for high-risk population, and they quoted a cost-effective analysis study that did not show cost-effectiveness in screening high-risk population. The European acknowledged there's no cost-effective analysis, but they said the disease is too high risk, we're gonna screen for it. What they did, they said metabolic risk factor, you start with ultrasound with or without liver enzymes. And if there's no fat or the enzymes are normal, you're done. But if there's a steatosis with or without elevated liver enzymes, you need to check for fibrosis. So the European screens for it. So as I said, I'm not gonna spend a lot of time on ITs. I'm gonna spend time on simplifying it for people. So this is what Zubair showed, and everyone knows fibrosis matter, F2 and higher, what correlates with morbidity and mortality. This is the principle. And we do have non-invasive testing that can look for them. So this is the toolkit. We know the FIB4 NAFLD fibrosis score. There are more coming, and there's imaging-based that Rohit is gonna probably touch base on a lot of them, especially in the specialist spaces. This is the FIB4 that we all know of. Caveat of FIB4, there's a study published that I'm gonna talk about tomorrow that FIB4 over time varies and it fluctuates. NAFLD fibrosis score is probably less popular than FIB4 now, so a lot of people are relying on FIB4. ELF now is probably either in the market or about to make it to the market in the US. Tomorrow I will show some correlation with outcome data, and it's a combination between hyaluronic acid, P3MP, and TIMP1. So those are serum-based biomarkers. And finally, probably FibroScan can be used one day if the price makes sense for primary care, if they do adjustment on it. So how can we move the needle in primary care setting? So you need three things: cheap, cost-effective, easy to use, and reliable, accurate. If you give the primary care these three things, it's gonna work for them. Otherwise, it's not gonna work. So cost-effectiveness, Maru, I, and Dr. Dietrich, and the NASHnet, we did cost-effective study that we published in Gastro this year. So this is what we did. We said, let's screen type 2 diabetic patients. And we started with ultrasound and ALT, ultrasound AST, or ultrasound alone. And if we detected fatty liver, we offered the patient either liver biopsy or liver biopsy followed by FibroScan or a FibroScan. And compared to the last cost-effective analysis study, we have the new information on F2 and higher correlate with morbidity and mortality. So we said we're gonna detect F2, and then we also had a newer intervention, which is the Villar-Gomez data that intensive lifestyle intervention reverse fibrosis. So we relied on that as a primary intervention. And of course, liver biopsy was not cost effective. We took in consideration HCC data and liver transplant data. So wherever you had a liver biopsy data, it was not cost effective. And when we used the transient elastography to find F2 and higher, it was cost effective. We chose transient elastography because you detect F2. Of course, if you use FIB4, it's much cheaper, but you go to the F3. So these data showed cost effectiveness in screening the population at F2 and higher. This data went all the way to age 40 and higher and was also cost effective. So the recommendation is to screen type 2 diabetes at age 40 and higher for NAFLD. This is an effort was started by Zubair, published in APNT, directed toward primary care physician. And we said, forget about the indeterminate zone and don't confuse the primary care. If FIB4 is 1.3 and higher, tell the primary care to refer. But also, and this is in high-risk population, but also we introduced the risk of a second test to increase accuracy. And there are a couple listed here, such as transient elastography or ELF. And this concept actually was well tested in such a study. So this is an European study that is well cited now, that they started with the FIB4, and then if the FIB4 met the 3.2 and higher, the patient was referred. It was low, the patient was not referred. But if it fell in the indeterminate zone, the test was followed by the ELF, and was more than the 9.5, the patient was referred. So this two steps algorithm reduced referral by 80%. Of note, most of the saving was from the FIB4, but the ELF added a proportion as well. So this is like simple and easy for them, rather than throwing 10 to 20 tests, and that's what we need in their test. Finally, we all have EPIC. We live in EPIC world. So this is an example of diabetes best practice, and we can easily implement FIB4, and in the future, you can either add ELF or another test to make a referral or trigger referral from primary care to GI or hepatology practice and help our patients. So in few words, we have to teach our primary care endocrinologists and hopefully implement in their guidelines how to screen high-risk patients. We can start with one NIT, but hopefully with two. Those with advanced fibrosis can be referred to a hepatologist, and we would do our own thing. But those with low risk, we need to work on those as well so they don't progress. And the primary care endocrinologists do this all day. Weight loss, exercise, managing their type 2 diabetes. Manal just published a paper about the correlation between the severity of type 2 diabetes and NAFLD. We can manage that, hypertension, dyslipidemia, and we can have a real partnership. With that, I would like to thank everyone for listening. Thank you.
Thank you very much, Mazen. So the next talk that we'll have is NASH screening and diagnosis in specialty clinic using radiologic modalities and fibrosis markers by Rohit Lumba. Rohit, again, is a leader in the field and is the professor of medicine, I'm correct at this time, and UCSD, as well as the vice chair of the Department of Gastroenterology and also the director of the liver clinic, a well-known authority in NAFLD. So welcome, Rohit, please.
Thank you, Zubair, for organizing this NASH Summit, and thank you to all the colleagues who are here, and to CLDF for organizing this wonderful event. These are my disclosures. One more disclosure I have is it's really, I was overjoyed and thrilled that Maz was giving a talk right before and Maz and I worked together at UCSD, and I'm so proud of him for all his achievements and the wonderful things that he's done and taken non-invasive assessment of NASH and fibrosis to the next level. So great job, Nash and Maz, for all the things that you're doing at Cedars-Sinai. I'm very proud of you. Thank you. So I thought I'll briefly cover three aspects on epidemiology and briefly talk about genetics, new advances in non-invasive assessment, and then focus mainly on predictors of response. So there's less overlap with what Maz already discussed. And then he has a wonderful talk tomorrow where he'll go in greater details. So as we know, both the first two speakers showed us that 1 billion people worldwide may have NAFLD. There's a clear ethnic predisposition. Asian Indians have the highest predilection, followed by Hispanics, then Caucasian, and then African American are predicted. And the risk factors do include metabolic syndrome. There are three genetic risk conferring genotypes: PNPLA3, TM6SF2, MBOT7. And then there is a protective genotype as well, HSD17B13. All of these are going to be very, very relevant in terms of treatment of NASH and NASH-related fibrosis in the coming years. Now, how do we diagnose NAFLD? It's diagnosed either on a biopsy or an imaging modality. The reason I always put this definition is because anything that we discuss or talk about really centers around the definition, and sometimes people don't even agree on definitions or don't have clarity on it. And that's why you will see the case identification is different. Many primary care physicians may not even know that the case definition is either on imaging or biopsy. They might assume an elevated ALT could be suspected NAFLD or NAFLD diagnosis. So I think it's important to start with this in individuals who consume little or no alcohol without any other secondary cause for hepatic steatosis. These data just show that NAFLD associated with increased all-cause mortality as well as exponential increase in liver-related mortality. The key difference here is that once you jump from stage 3 fibrosis to stage 4 fibrosis, the proportion of patients dying from liver disease exponentially increase. And this increase is 8 times higher. So you have a stage 3 patient, the risk is there, but it's predominantly cardiovascular disease and cancer. And once you go to stage 4, 25 to 30% mortality is attributable to liver disease. Now, who needs to be treated is important in context of what you want to identify. And so I think I've lumped them into these 5 categories. NAFLD stage 0 to 1, these would be candidates for lifestyle interventions, reducing CVD risk, reducing long-term cancer risk. NASH with stage 2 fibrosis or higher, these would be the ones where we would need pharmacologic therapies after lifestyle interventions. NASH with advanced fibrosis could be utilized in therapies that may have narrower therapeutic index. So if you have a therapy that is likely to improve liver disease, but potentially might increase risk for other causes, then you want to stratify and pick patients who are at a much higher risk for progression for liver disease. And then NAFLD cirrhosis as a separate entity, followed by NAFLD cirrhosis with decompensation. Very few therapies there, but I think they would be coming in future. There are 2 organizations that are working on non-invasive biomarkers as consortiums. One is NIMBLE in the United States, and then Litmus in Europe. And in NIMBLE, we are now into our second year. Phase 1 is going, and our goals are to diagnose or detect biomarkers and qualify them for FDA approval for who needs to be treated, that is NASH stage 2 fibrosis or higher. And then how do you assess treatment response in the setting of a treatment that's working in NASH? So those are 2 aims for NIMBLE. And Litmus has similar aims, but it's covering discovery as well. Maz discussed FIB4 and NAFLD fibrosis score. So I'm going to skip this slide and move to the next one. And then we also looked at ELF score. The cut point here, 9.8 or higher is associated with advanced fibrosis based upon some of the seminal work done by Stephen, as well as Arun and Zobair using the STELLAR data. So can longitudinal ELF data predict progression to cirrhosis and liver-related outcomes? The answer is yes. And then what would be that cut point if you were to identify? Is it an ELF of 8.8, ELF of 9.8, 11.3, or 14 or higher? So the question is, if you saw a patient with stage 3 fibrosis in your clinic today, within that group of patients, 20% are going to progress over the next 2.5 years. And can you identify who those 20% would be? And it'll be, if you did an ELF and ELF was greater than 9.8, then among those bridging fibrosis patients, you can still further risk stratify, and that would be the use of such a test. And this is the data where it's coming from. Now, looking into once you have cirrhosis, in a patient with compensated cirrhosis, can you predict which patient is likely to progress to a decompensation over the next 2.5 years? This you can also predict using an ELF score. So I do not randomly suggest doing an ELF, but I think in these settings, once you have identified a patient, I think it's good for further risk stratification. Of course, at the level of population or even the clinic or referrals or which patient should see you versus your nurse practitioner, you could potentially utilize FIB4 and potentially utilize FibroScan and MR elastography. We'll see how we can use those. And several institutions have applied that in their clinical practice. This is one example. And so you could start with a FIB4 assessment. This could be done at the level of primary care or at the time of the referral. You could potentially classify patients at low risk if their FIB4 is 1.3. One caveat to that is understanding that you're excluding advanced fibrosis, but there might be many patients who have stage 2 fibrosis who will be in this bucket. And how do you identify that? I think you want to look at additional risk factors. So this is not a perfect algorithm. You're going to miss a lot of patients who have NASH, stage 1 to 2 fibrosis, potentially some with stage 3 fibrosis as well. So once the patient is coming to your liver clinic, you may want to do some additional testing. And the other thing we've learned in patients with diabetes who are 50 and older, that we have to use a lower FIB4 cut point of 1, because there are patients, about 3%, who have advanced fibrosis who are missed. The thing is, if a patient sees you, you're a hepatologist, the buck stops there. So I don't want to misdiagnose a patient based upon a FIB4 assessment. This is good for the primary care, but the patient, when they come to see me, I want to give them the best evaluation that they deserve with me, because they will consider that they don't have advanced disease. So it's important, and typically we'll have another test done. It could be a FibroScan, it could be an ELF, it could be a FibroSpec2. Manal and I had developed some data on FibroSpec2 that a cut point of 17 or higher is associated with advanced fibrosis, similar to ELF in terms of diagnostic accuracy. Now, once the patient in our clinic, this thing gets lost a lot. We should look into what else is going on. Many times I'm seeing drug-induced liver injury. A patient is on a drug that leads to elevated ALT. They have concomitant fatty liver on imaging, and that's not the reason. I just saw a patient with ALT of 273, AST of 78, labeled as fatty liver, and it's not the case. I think I suspect that she has fatty liver on imaging, but the ALT and AST elevations are related to the atypical antipsychotic she's on. And so I think this history is very important, and that's why I think FIB4 assessment in a hepatologist clinic should be viewed, because many times you would have a low FIB4 for many of these patients who may have something else going on. You might also miss autoimmune hepatitis in a patient who is obese and has fatty liver on imaging. Again, the same reason would apply there. So I think we need a little bit more assessment before shunning the patient that just because the FIB4 was below 1.3, they're in your clinic, that they don't have a liver problem. In terms of looking into elastography methods, if the BMI is 35 or higher, many of the ultrasound-based elastography methods do not perform very well. So anyways, the diagnostic accuracy is somewhere around 80%. It just drops down to 75 to 70% in those patients. For MR elastography, we still see pretty good performance up to a BMI of 40, 42. Caveats to MR elastography is that if you have significant iron content, then the MR elastography may fail. So we use a different sequence to then use spin echo to qualify in those patients who have significant iron overload. And you can look at the ferritin. Another caveat I'll tell you is many patients are iron deficient, and you're giving them an iron infusion. If you gave them an iron infusion, you don't want to do an MR elastography, it will fail. within the next 4 weeks. So if you're timing it, you want to do your MR elastography, 2-3 months away from that iron infusion. It's not going to work. So if the MR is E shows below 2.55, that patient has minimal risk for fibrosis, and you can avoid a liver biopsy in that case. FibroScan, many practices are using 7.5 as the cut point. Below that, they're not assessing or doing a biopsy. In our hands, I think you want to look at things in totality. Definitely below 6 is pretty safe, and those patients are very low risk, everybody would agree. If you're enriching for a treatment trial, that's a different question. That's not for that particular patient's assessment. And for those, of course, we want a higher VCT cut points so we don't waste resources as the patients are coming into the studies. So I think low risk for advanced fibrosis, you could use a cut point of 7.9 kilopascal VCT or below, or MRE 2.99 or below. Raj Bupalanchi and I just wrote an editorial in Hepatology looking at totality of all ultrasound-based modalities. This is a paper that was written from France, and we kind of try to simplify things. So based upon that paper, if the VCTE was consistent and a good read, if it was below 8, the likelihood of significant disease was minimal in France. And then 8 to 12 was sort of where you see fibrosis. 12 and higher, you start seeing more advanced fibrosis, pretty logical. But again, 12 or higher doesn't really mean that they have cirrhosis. Many of those patients may have, just fatty liver stage 1 fibrosis. That's pretty common that we see, especially those with a BMI of 40. Higher BMI, you overestimate liver stiffness, and you may underestimate CAP or liver fat. So this is the hierarchy of imaging-based modalities, along with the CPR. Of course, CPR lowest accuracy, with MR elastography highest accuracy. This is a recent paper that we wrote with the Broad Group. Kathleen Corey and others were also involved in this. And I think in future, Manal and Duke will be involved in this assessment as well. We looked at multiple genes that may be associated with cirrhosis in general. This study had over about 70,000 controls, 4,000 patients with cirrhosis. So it's a very big study. In this particular assessment, of course, PNPLA3 pops out, but the most important trait at the level of population is SERPINA, which is the alpha-1 antitrypsin gene. So I think it's important for us to still see patients who are heterozygote for alpha-1 antitrypsin. We routinely do that screening in our patient population, but that might be an added risk factor in a patient who's overweight, obese, maybe drinks a little bit. Those patients will have, especially men, have a high rate of progression. These are important for genetic risk stratification, but also as treatment targets. Now we know that we have treatment target for PNPLA3, TM6SF2, SERPINA, MARC1, and HSD17B13. So you can see we've got 5 new streams of treatments that are coming up based upon this non-invasive assessment on genetic risk score. In terms of FAST, this is looking at Phil Newsom's data. One issue is, looks great, but you have a higher cut point of 0.67. That would be associated with NASH with stage 2 fibrosis higher. What is the diagnostic accuracy? The key thing is you want to know what the positive predictive value is. So the positive predictive value really ranges from somewhere around 0.6 to somewhere around 0.83. And I think that's something to keep in mind, because even if you do this test, the likelihood will really have a big range. The other thing that was done here is, at least in the training set, they had sequential FibroScan. So even before the patient got referred for this FAST assessment, they had a FibroScan, and based upon that elevated FibroScan, that's when they came to see a hepatologist. The thing is, in UK, they really don't want to see the patient. In the United States, it's different. We want to see the patient. So they want a barrier so the patient doesn't get referred to them. We want all patients coming to us, and then we want to have a system to risk stratify. So it's really 2 different systems. This would work very well, in a VS system, again, with the same strategy that we want to create say, cost saving by less referrals. That's their idea of medicine in the UK. I think our idea is to try to find out all those who need treatment to come in and capture. Now, you could exclude patients if you had a lower cut point of 0.35. Of course, this would have a good negative predictive value, but this is pretty low. Majority of our patients would be somewhere between 0.35 and 0.7. This is a study that we did at UCSD, developed a score called MEFIB, and then had a validation cohort in Japan. The idea of this paper was to come up with a criteria where you have a high positive predictive value. As clinicians, we want a test. If it is positive, then the patient has a disease. I just want to know that. And it may not be perfect. We cannot classify everybody. But when it is there, you don't need a biopsy. It's a guarantee. So you have a positive predictive value of 97%. You can do better than that. And then we did a validation, and the positive predictive value in Japan is 91%. So if you had an MRE of 3.3 and a FIB4 of 1.6, you don't need a biopsy, and these patients need treatment. Again, you can say, oh, what about cirrhosis? Well, if the MRE is above 6, that patient has cirrhosis, so you could potentially risk stratify based upon that. And also looking at their FIB4, if the FIB4 is above 3.25, that patient would be at pretty high risk for cirrhosis. So I think there are ways to stratify. This way, you would probably capture 25% of patients. Others would still need a biopsy, and that's totally fine. Predicting treatment response. This is a paper that we wrote along with a group of collaborators. And what we found was ALT decline within the first 6 months predicted response. And this has a 10 times higher odds for predicting treatment response in NASH studies. I think this would be true for most drugs. We know as clinicians, if a patient is responding to treatment, their ALT improves. Here we came up with a cut point of 17 units. It may be 17 or a 30% reduction in ALT compared to baseline. Many of the trials are now using 2 ALTs for in screening, show stability, take a mean of that, and then show reduction over the next 24 weeks. Now just showing you a proof of concept in the Regenerate trial that treatment versus placebo, there's a big decline in ALT. Typically happens in the first 6 months. You continue to see improvements further down as well. And then in terms of FibroScan, within the first 6 months, we don't see significant improvements. We see a trend, but as you go towards 18 months and 2 years, you start seeing a greater improvement. Of course, the issue is that not all patients have had those assessments, and maybe we are excluding patients who stop treatment on their way. Despite that, I think there is clear data showing that treatment versus placebo, there is a big difference. So this can be used for assessing treatment response over 1 to 2 years. So no point doing a FibroScan at 6 months, in my opinion. Combination therapy and NIT data. This is some of the data that Naim presented at ASLD. Just looking at a combination trial with sema per persocostat, which is an ACC inhibitor, or salofexar and FXR inhibitor, or the triple combo. Now, what we are showing here is to the left is improvements in liver stiffness. And so when you combine 2 drugs, one is a GLP-1 leading to weight loss, along with a liver-specific target such as a ACC or FXR, you have further improvements. So you can see proof of concept document synergy this way. To the right, I'm also showing you changes in the liver fat. And of course, you can have additive benefits once you combine, predominantly being derived from combo between sema with the ACC inhibitor. We saw similar improvements, additive improvements in synergy in terms of ALT, AST, GGT, as well as ELF. This is showing you the VCT data in absolute terms, and then number of patients achieving 25% reduction at week 24. Again, these are not significant, but it gives you a trend that combination probably is giving you greater bang for the buck than monotherapy. This is looking at FAST score, again, predominantly driven by AST improvements in this. Of course, it can also be potentially utilized to assess treatment responses. Maz has come up with, along with Naim and Stephen, MRI plus MRI PDFF and a combo score. I think those would work as well, in my opinion. What is a clinically significant reduction in MRI-PDFF? Very briefly, we think a 30% reduction in PDFF is associated with histologic response. And we confirmed those from our previous study in the Flint trial, showing 29% is associated with higher odds of histologic response, also showing as you get greater reduction, so you go from 25 to 50, to the left, you see higher odds of histologic improvements. This is just looking at the rate that you see. So if you hit a 30%, you have about 50% histologic response compared to 19%. So it's not absolute that, okay, if you don't hit it, you've got 0%. That's not the case. The idea is, can you see treatment response in 12 to 24 weeks and take the drug forward into a larger histology-based assessment? This is really wonderful data that came about with collaboration with Becky Taub from Madrigal and Stephen Harrison, where we looked at PDFF responsive as prediction in future improvements in liver histology. So 12-week response on PDFF was associated with 9-month improvement in histology, consistent for NASH resolution, as well as even fibrosis here. This is the first study where PDFF improvements were associated with fibrosis improvement, although we want to confirm that, but you can see significant odds ratio. We also developed a cut point, which is a super response, which is 50% MRI-PDFF reduction, and that is associated with significantly higher odds, which is 25 times higher odds for histologic response. This is a meta that we did last year, giving you a pooled odds ratio. This is helpful as you're developing sample size estimates for your treatment trial. So for NASH resolution, for the PDFF response, 5 times higher odds ratio, and for 2-point improvement, it's 7 times higher odds ratio. So in terms of PDFF response criteria, I think this is now well accepted. Most trials are reporting 30% in terms of their primary or secondary outcomes, and this is consistent across 7 different trials now. So in summary, non-invasive assessment is taking the center stage in risk stratification. Fibrosis improvement requires long-term treatment and typically requires liver-specific targeted therapies. MEFIB could potentially be applied with a high PPV. FAST could be applied as a point of care to screen patients in liver clinic. And then the MRI-PDFF response, defined as 30% relative reduction, is associated with 2-point improvement in NAFLD activity score and NASH resolution. Thank you.
Thank you very much, Rohit, for this wonderful presentation. So we actually are going to go to a little bit of a different format. We'll do a case presentation. Ann Moore, who is a nurse practitioner here in Arizona Liver Center, is going to join us. She'll be presenting the first case. I'll ask Mazen to join us as well. So this session is intended to be very interactive. I'll try to actually engage the faculty, but also will engage some of you guys in the audience. There will be some microphones that will be given to you so that you can actually share with us. So the first case is going to be about linkage to care and the use of NIT. So Anne, welcome.
Hi, thanks to the CLDF for asking me to be part of this esteemed panel. I'm honored, and also honored to represent the NPs and PAs out there who I think play such an important role in the management of fatty liver disease. So we'll get started. Hopefully this case will act as a kind of a sounding board for some robust discussion amongst the panelists. So with no further ado, let's meet Elena. Elena is a 55-year-old Hispanic woman who's referred to your clinic with elevated LFTs from her PCP. So this is the #1 referral diagnosis into my clinic out of all liver disease. And I'll take a little aside here for the LFT comment. We get a lot of referrals for elevated LFTs, but if you look at the labs for Elena, you'll see that her actual LFTs are normal, her albumin and her bilirubin are completely within normal limits. It's her ALT and AST that got her into your clinic, right? So this PCP is pretty sophisticated. So the PCP has obviously heard Dr. Naredin's lecture on how to link patients in their clinic to specialty care, and he did some testing before referral, and ultrasound that was suggestive of hepatic steatosis was done. Also, he did a liver disease workup, a very basic liver disease workup. We know that Elena does not have viral hepatitis, nor does she have any autoimmune markers or other coexisting liver disease to our knowledge. Elena does have some risk factors for fatty liver disease. Her BMI is 33. She has hypertension. She is not diabetic. Also, her alcohol history is kind of insignificant, 1 to 2 drinks per week. ALT is 65, AST is 52, everything else looks pretty normal. So what do you think the odds are that Elena is going to have NASH?
Mazen, what do you think?
It's a good odds. I mean, she has risk factors of metabolic syndrome, maybe the waist circumflex. She does have hypertension. She's not diabetic. I don't have her lipid panel. I also, if I want to calculate the FIB4, the AST and ALT is not flipped, but maybe it will fall in the indeterminate zone. So, I mean, she will alert me overall. So this is someone that I will get, pull my iPhone and do the FIB4 calculation. I don't use, honestly, FIB4 much in my clinic because I just have a FibroScan. I'll just take her to the room and do FibroScan. Definitely, she's someone who will require staging from me.
Do you believe that no history of diabetes? Looking at her picture, she's, postmenopausal Hispanic female who's carrying a lot of weight around her abdomen. Would you want more information about that? She's likely insulin resistant.
Sure. I mean, she, as mentioned earlier, we have 34 million with type 2 diabetes and 88 million with pre-diabetes. So she could be pre-diabetic or insulin resistant. And what we see in our clinics on average, the NASH and even those with advanced fibrosis, almost half of them, they're not diabetic. So I say the type 2 diabetes are the elephant in the room. They alert us, but at the same time, half of our patients are not type 2 diabetics, and still many of them, they have advanced liver disease. So we should not forget about those.
Rohit, so if you look at this patient, and we know they don't have diabetes, I mean, looking at this picture and that clinical, what do you think is the chance of having fatty liver disease? 5%, 10%?
I think, so I just want to first, I'll answer your question, but you asked about a question about what are her odds. So you can change the odds because odds has a denominator. So compared to what is the odds? So this patient can have 20 times higher odds compared to African American with a normal BMI or normal ALT. So I think this patient is a pretty high risk for NAFLD. And to your question, if you look at obese Hispanics, suppose she's in San Diego, she, just based upon that, she has 80% risk for having hepatic steatosis, which we already know from her ultrasound. I think she is a pretty high risk for having NASH and a pretty high risk for having fibrosis on the biopsy. Of course, we won't be jumping that, but the reason I'm saying it is based upon her AST. Typically, I would not be assessing and making that judgment just based upon one lab value that I have on this patient, but just looking at the presentation. Some of the things that I go into in history is, duration of ALT and AST elevations. Typically, I'll go back in medical records. It'll be from last 10, 15 years. Overall body weight dynamics in terms of how long you've been overweight and obese. Most patients have been overweight and obese for 20 years. She's particularly postmenopausal, Hispanic. All these increase her risk. Why Hispanic? Because of PNPLA3. She has a 25% chance of being PNPLA3 homozygotes right now in this setting based upon her ALT. So I think she would be a pretty high risk. Platelets are reassuring that she has 235. Albumin is on the lower side. Typically, if I'm looking at a patient like that, I would still expect an albumin of 4. She's on, above a 4, but she's 3.8. So I would be concerned about that. But I think she's going to have a full workup in my clinic for looking at, other metabolic risk factors, including ferritin, including alpha-1 antitrypsin, as I mentioned. And also, I take detailed history about family history for their liver disease, cirrhosis in their family. And I'm finding that about, 5 to 10% of patients have a family history.
So we actually asked 3 questions. One, you say that you're going to do a full workup. You're going to do ferritin, you're going to do alpha-1. Why? I mean, the ferritin is going to be high. The patient probably is insulin resistant, right? I mean, fatty liver by ultrasound is a sort of surrogate of insulin resistance. So why do we do this?
Yeah, I think there are 2 things. When the patient comes to see me, the buck stops there. I won't be doing all that detailed workup if the ALT was 19. But this patient is deserving a workup for both elevated ALT and AST. I'm thinking she probably has it for several years. So I think a detailed workup in my setting would be necessary. If I were to have a family member see somebody else, I would want them to do that as well. Because I don't want somebody to be missing alpha-1 antitrypsin because I'm seeing heterozygosity is pretty common. And I also pick up homozygosity. Other things that I pick up in my clinic, although rare, is combined variable immunodeficiency. About 1 in 50 patients that I see, I'll pick up based upon their immunoglobulin levels that I check. There are other liver problems that you pick up for elevated ALT and AST.
I agree. I always tell patients, if you're in my clinic and I miss coexisting liver disease, that's on me. I mean, you just don't want to do that.
That's actually, I think being actually complete is of course important because the buck stops with us. But it's actually the second point that you just raised, which is that because of the high prevalence of NAFLD or metabolic conditions, with all liver diseases, you don't want to have coexisting liver disease of someone having hemochromatosis or alpha-1 in this context and having the additional hit of actually having superimposed fatty liver disease. Now, coming to you, Mazen, 1 to 2 drinks per week is basically what is the cutoff for alcohol in someone? We always talk about the 1 to 2 drinks for women less than 1 drink per day, for men less than 2 drinks per day for the studies that we do. But what is the reality in the context of multiple components of metabolic syndrome? Because if you look at methotrexate sort of toxicity, it was fatty liver, it was obesity, right? So, in the old stories of methotrexate toxicity. So do we actually have a fair assessment of what is a safe cutoff for alcohol consumption in patients with risk factors for fatty liver disease?
Sure, at 50 for women per week and 150 for men per week. No, so the guidelines that for men, I think it's 21, the ASLD guidelines are currently 21 for men and 14 for women per week. And a lot of us use the 14 and 7 per week, but I think it's an area of controversy that needs more studies. And there's this debate about, is wine beneficial and not beneficial? And there's back and forth about that. There's also the existing field of having baffled and BASH if you have both diseases. So I think it's ongoing field. I use in my clinic 14 and 7 as cutoff, and I tell them it's a restaurant drink, and I quantify it, and in studies we use the surveys.
Well, maybe I can ask the audience if they have any specific question related to this. Actually, I'm going to ask Mauro Rinella to talk about what you just said, a word that we need to at least address where we are, because we do hear it actually, especially for our colleagues who are on the virtual side of this meeting, this term MAFLD versus NAFLD, and how do we sort of address this? Mauro, do you want to comment?
Oh, we're going to start the MAFL talk. Wow.
You have 20 minutes.
I believe that, especially based on some of the comments that Rohit made about genetic markers and the way, and Stephen's going to talk about clinical endpoints, I think that it's extremely premature and I think short-sighted, and I think a little bit simple-minded in a sense to just think that you can change the name of the disease by replacing the N with the M and achieve anything meaningful. So I do agree that NAFLD is not really a good name. And I think we were discussing this in Atlanta in 2002. So I think it's not a new concept. But the problem is that to change the name without any meaningful sort of meat behind it that reflects changes in natural history, a treatment response, and to think about what that's going to mean for the drugs in development, how the FDA is going to approve medications, I think is just really short-sighted. You know, for example, I think that we are close to getting to a point where we can actually phenotype people a little bit more meaningfully, such as using genetic risk scores or other things, so that we can then, when we do change the name of the disease, say, okay, this is, you know, subtype 1, 2, 3, or whatever you want to call it, but then at least there's meaning behind it, and it'll help us with drug development, it'll help us with disease awareness, because we're like rolling out something that means something rather than we like it because metabolic's more accurate. I mean, that's sort of the way I look at it. But.
Thanks, Mauro. I think that's a very important issue, and just to mention that Mauro is and a number of us in this panel, in conjunction with both EASL and also the European Society, as well as the APOSL, and actually the ELAHID actually are coming together to really go through the steps of what is it required to make a name change. And a number of us, including Rohit and Mauro and Stephen and I, actually published something in Hepatology and another one in Journal of Hepatology to address this issue, because it's not as simple as to just, you know, flip a switch and really not have any other consequences. I think this is an important topic that we need to address. And there's a question right there.
I think we went through the name change with PBC, so we know what a struggle that was. It's going to be similar to get a name change accomplished.
I think the PBC name change made sense because a lot of people labeled with cirrhosis, and it needed to be changed to cholangitis. Here, as Mauro said,
that was still difficult. So
yeah. Here we're trying to move the field, find a treatment, and then all of a sudden someone said we should name it MAFLD, and we're struggling with the disease. So
Bob.
2013, I was in London at a PBC meeting at the Royal College of Physicians. I stood up in front of 200 people and proposed the name change for PBC. David Jones basically shot me down in front of 200 people, said this will never happen. We've discussed this for 20 years. There's no reason to do it. And it was just an interesting discussion. 2 hours later, in the wine and cheese reception, Robert Tane Mitchell, who helps run the PBC Foundation, and I went back to David, talked to him for half an hour about stigma, insurance, all sorts of other issues that are related to that name. That started the tide with Ulrich Buers. We had 7 publications, 7 journals simultaneously. The name change came out. Both stigma and other things need to be included in this assessment. And non-alcohol, putting alcohol somewhere in there is wrong. So we need to think of a new term. Thank you.
No, I think, Bob, that's an important point. I think what Mauro was actually suggesting and what we are suggesting is that has to be done intentionally. That has to be done with a team to actually look at both pros and cons. Because for PBC, there was a lot of actually thought behind how to go through this change and what was the positive or negative impact of that change. And they actually, the point you made was a positive change for PBC. Here, there are potentially a lot of negatives that we need to understand. At the end of the day, we may call it MAFL, NAFL, or something completely different at the end of the day, but it has to be done carefully, correctly, with an assessment of everything, especially in the context that we have a disease that's actually affecting 25% of the global population. PBC is not in that context. And that awareness is less than 5% and among everyone, and especially in the policymakers and also general population side of things. So the potential impact of making a wrong decision to make the change is really why we're all sort of being careful with this. Any other comments? Go ahead.
I think, Bob, you raise a very important issue because I think it's patient perception and stigmatization. Thing with PBC was primary biliary cirrhosis versus primary biliary cholangitis. The definition of the disease did not change. The main issue with that worries some of us is that from NAFLD to MAFLD, the diagnostic criteria is going to modify. What that does is it changes the natural history of disease. And then we need to identify, do we still call NASH NASH or NASH goes to MASH? And so when that happens, we need to have 20 years of natural history data to take to drug developers that we need a drug for this particular disease. So that's the major difference where we want to modify, but we don't want to erase the history of all the work that has gone into natural history of disease. Now we've actually had patients with NASH stage 2 fibrosis or higher can be treated. We've got a endpoint for drug approval. All this is at risk because suddenly FDA can say, you've got a new disease, we want new natural history data. Of course, it can all be done, but I think having that in context is important for both drug development, endpoint for trials, and also for biomarker development.
I just want to make one last comment. So I completely agree with Rohit, and I understand what you're saying, Bob. And I think part of what we're trying to do is actually do a proper Delphi process to reach consensus. So we're currently at the stage of working groups developing critical, questions and statements that are then going to be distributed broadly to be scored on a Likert scale, to be able to really understand kind of where the sticking points might be. Patient groups from the United States and from Europe are actively involved in these working groups, as well as we'll have regulators and we'll have, of course, academicians and general gastroenterologists ultimately at the end. And there'll be a consensus conference probably in the summer of 2022, and we'll do an update probably at the beginning of 2022. The consensus conference will be an in-person event. And so we really hope to come up with all of those little details answered, and so that we all, feel good and that we've addressed the critical issues of, endpoints, natural history, treatment response, et cetera, because it's a little bit more complicated than the PBC thing, I think.
Thanks, Maru. Now that we have resolved the issue of NAFLD and MAFLD, we'll just go on with our case.
So,
Please.
all right, so I told you that Elena's PCP is pretty sophisticated and was aware of non-invasive testing, and so just quickly calculated 3 simple tests, and all of them fall within the indeterminate zone. And so at that point, he just threw his hands up in the air and said, what next?
Do you guys use any of these? I mean, Mazen, you told us that you personally don't use, but what do you tell your primary care physician? What tests to do first?
Yeah, I actually focus on the FIB4. I tell them if you can do FIB4 only, and if it's more than 1.3, you can refer. That's all I'm focusing on right now. I know it's gonna cause overflow for now, but if I can grab their attention to just the FIB4, they still don't do it. But if they still refer based on ALT and AST and steatosis. But if I can just teach them one thing, that's an accomplishment.
Do you enrich the population, saying that you need to have abnormal liver tests, or you have to have diabetes, or be obese before you do a FIB4?
It's type 2 diabetes and age more than 40. That's what I tell them, and it's more focused on the endocrine clinic. And that I think the screening should be done on type 2 diabetes, age more than 40.
Steve?
Is it working now? Okay. So this is the problem with these non-invasive tests. They're you roll the dice on whether they fall in the indeterminate range. So when, my comment, if I were up there and you ask if this patient has NASH, this patient has NASH. It's like saying, do we need to screen a diabetic for fatty liver? They have fatty liver. That's just the assumption. 55-year-old, likely postmenopausal Hispanic female with an AST of 51 or whatever that was, obese with hypertension. That's metabolic syndrome, essentially. We didn't see the lipid panel, I don't think, but
No.
this lady has metabolic syndrome. She's Hispanic. She's in a high-risk group. So all this did was confound us. Okay, now it confused the primary care provider because they're like, okay, well, all these pretest probabilities are putting her in a high-risk category. I do this test, and then it's the now what scenario. So that's the downside. The negative predictive value of all those are incredible. But what do you do when it's indeterminate? We know what to do when they're high as well, but this is the perfect conundrum. It's driven, you got to go back to the pretest probability. This patient has NASH, so that needs to be worked up with that thought in the back of my mind, at least when I see this patient.
Right, I oftentimes find that suggesting to primary care that they do non-invasive testing, just simple non-invasive testing, just confounds the issue even more. So if they have a patient who has risk factors, it's my opinion, just refer and we'll figure it out for now, because we really don't have a great way of narrowing down the gray zone of indeterminate.
The simplest test you have there is
results.
the AST-ALT ratio of 0.8. That odds ratio for advanced fibrosis is 9. So, I mean, just rolling the dice, this is at least F2, maybe an early F3 patient.
Rohit, so there are not a lot of gastroenterologists or hepatologists available. So we have to somehow, in the potential population that will have this specific profile is large. How do you suggest and I understand what, Stephen is actually doing a lot of these things because he's so experienced, but do you suggest we actually put some of these things in a electronic health record where it can actually flag? Because, primary care physicians are really busy. They don't have time to do another thing.
So I think what you're mentioning is sort of making sure that the patient gets picked up. So I think, Zubair, that's very important. And we have routine calculation of MELD. So if you do .MELD in our Epic, MELD score gets calculated automatically and puts in the date and the time of those labs. I think something similar could be done with FIB4. And I think to Stephen's point, this is when they're not thinking about it, but the patient shows up, say, oh, flag, acknowledge that you have seen that the FIB4 is greater than 1.3 or higher. And if that's acknowledged, then they say, yes, acknowledge, and then it could go to the next one. Would you want to send this patient for a FibroScan or a liver referral? You can give both those options. So that's a possibility to stratify.
So can I?
Bhavgesh? Go ahead, Mazen, and then Bhavgesh.
Just to Stephen and the other points, I think also there eventually, if it goes to the guidelines, we have to be careful also not to overflow the system. So Stephen, your point is very well taken about these biomarkers, and I think the study that was done in the primary care doing, for instance, the FIB4 that fell in the indeterminate zone followed by the ELF will solve such a problem. I mean, let's say this patient is F1 or not, or just NASH. You're probably not going to have therapy for her, and it's just going to be probably just weight loss and exercise. And probably she's more well suited. She's not diabetic. She's probably more suited in a primary care setting than a hepatology setting. So I think that the message has to be consistent to them. And eventually, if we can, in my mind, FIB4 another test, short and easy message for them. In my mind, that will be the best solution for the primary care, because now they're not doing anything. If you tell them just high risk, that's what I'm getting right now. I'm getting a bunch of F0s and just simple steatosis because they're like, okay, just go to the hepatologist. So I don't know what's the best solution, but I think eventually we need a fine balance for the system.
Bob?
I've been working with Quest for a while on viral hepatitis, but I'm really trying to push Quest into the NASH space and have outputs such as NAFLD score or FIB4. But we have too many. I don't know which tests to say you should do, or you should do 3 or 4 tests. So your input to Hema Kapoor would be really good as you think about this. The last thing I want to ask as a question is, also I score all my patients with the Framingham ASCVD score, since heart disease is the worst. Why isn't the heart risk scoring going into our patient presentations? Anne?
So question number one, which one do you, and then there's a question and comment from that side also. Yeah, among all these, I think the easiest one to use and probably the simplest would be FIB4. In terms of diagnostic test accuracies, in NASH CRN, we compared 7 different scores. And among them, FIB4 had the best diagnostic test characteristic among the clinical prediction rules. So I only use FIB4. It's part of our initial patient evaluation, and that goes in there. I think it's a good idea to look at risk stratification. The main thing I always think about is what will be done with that information. So what I have is simple things, risk factors and their LDL cholesterol, and based upon that, I will have a note point, which will be patient has no contraindications to statin therapy. Please consider treatment of hyperlipidemia based upon 83B guidelines. So I think something like that can be easily added. It can be overwhelming to keep adding different questionnaires. So the two that we routinely do is for first patient assessment is, of course, FIB4 is there, and then the audit is what we typically use to classify alcohol use. And then in the assessment, I don't put the whole questionnaire there. In research, we do it because it takes much longer time. But I put my assessment that this patient needs statin therapy, and there's no contraindications to its use.
So I'm Michael McFall. I'm Senior Medical Director for Endocrinology with Quest. HEMAs in ID were very compartmentalized, and I'm actually very much involved in pushing Quest toward testing. We already have an NAFLD fibrosis score on our menu. We've had for several years. And we've actually been working with Ken Kusi and with Zubair and others to try and firm up a very simple approach for the stratification of patients both with and without type 2 diabetes. Our internal algorithm mirrors pretty precisely what's been talked about here, with diabetes primarily following first with FIB4, followed by stratification for ELF as soon as it's available. We've already partially validated that test, and we'll have it available likely on day one as soon as FDA clears it. The second thing, which has really not been discussed much here at all, it's been sort of implied, is how do you really risk stratify those individuals who don't have overt diabetes? And we've been very interested in this. I actually helped to get on our menu a tandem mass spec assay for insulin and C-peptide that we used to examine its utility, not only standardizing both assays across globally now, but also using it to assess global formal measurements of insulin resistance. And we did that with Jerry Reven's group, published it a few years ago. And it turns out that in non-diabetic individuals, that insulin resistance risk score that we've established is a very good surrogate for formal measurements of steady state plasma glucose, which is a very good measure of whole body insulin resistance. And that has an extraordinarily good ability to identify patients with fatty liver as measured by magnetic resonance spectroscopy. So what we are going to at least offer as our own algorithm internally is one entry point into that would be the insulin resistance risk score. Obviously, if the clinician's sensitive or has abnormalities of LFTs or something else, then it would still follow the same paradigm of FIB4 followed by ELF. And so we are interested in collaborations. We also still have a big hole in terms of the accurate identifications with patients with active steatohepatitis. So anybody who has any kind of interest in collaborating with a company who has the resources that we do, or pairing it up with cardiovascular assessment or other things, we'd be very interested in that. So thank you.
Thanks, Michael. I think that's an important point, that there are lots of these tests that are being developed. One thing I would say that diabetologists have no problem ordering a retina assessment for a patient with diabetes, or assessment of potential kidney complications. But primary care and other physicians would have a problem in terms of actually assessing for high-risk patients with NAFLD. I think what we need to do is to change that paradigm, that this is another complication of insulin-resistant type 2 diabetes and sort of metabolic conditions, that automatically people will think about some type of assessment. Now, doing a fundoscopic examination is established, but we need to find those tests that are simple, can be done to risk stratify these patients from their liver disease. Tarek, you had a question?
Just in the last 5 years, we have been working with primary care group that is very busy. And going back to the numbers that Mazen said, a provider is seeing 20 to 30 patients a day, and if the office has at least 2 providers, you're talking about 60 patients going through one office a day. Now, why the primary does the urine for the diabetics and they do the eye exam? Because there's a HEDIS form that they have to fill on which they get paid.
Yes.
So if they don't do it, they get the stick. If they do it, they get the carrot. And the carrot is, oh, I'm gonna give you $10 extra this month and you're paid. So to a certain extent, that's what drives them to do these tests. So unless they have a benefit out of adding an extra test and understanding how to order it, understanding how to do the interpretation, not like Anna's primary who knows a lot of things about these tests. Most primaries, they don't do that. I don't want to learn a new test, how it's going to help them. So how we resolve this issue, going to what Lumba said, let them send all the patient to us. When we were doing clinical trials, we were getting 100 patients to put 20 people on a study and 80% failures. We couldn't tolerate this. That's why we went into their offices and say, let's do the screening there. And we put a FibroScan. So FibroScan is expensive. Now we have new modalities coming that would be cheaper. And we stratified patients for them who comes to the liver clinic, who goes to the cardiologist based on markers or numbers, considering the question of this patient is going to die from his liver or his heart or not at all. So to a certain extent, why I think elastography can be very helpful in primary care for a couple of reasons. When we did a study of 1,300 patients, 800 of them had fatty liver by ultrasound or FibroScan, and most of them had normal, 90% had normal ALT. So the ALT alone didn't help. Now, in addition to FibroScan, that you identify some criteria who goes to which specialist, plus the markers for the cardiac, you can actually stratify these patients accordingly. Hence, the hepatologist will get patients who are at a high risk of fibrosis, although we still having a number of them who don't have fibrosis. The hepatologist does the MRE and the biopsy and so on. So we take it to the next step, not the FIB4, the ELF and beyond. So to a certain extent, if fibroelasticity measures becomes cheaper and available, and there's new efforts to do that, the primary care physician can bill for it, then it's a source of income and they are willing to do it. We are doing it today in primary care, and they love to do these things because now, let me give you a quick example. My primary care, if I'm under Medi-Cal, is getting $15 a month for my care. $15 a month. In a year, you're talking about maybe less than $200 to take care of me. If I do the new elastography and they can get $30 to $100, that's almost double their income for that particular patient. So we need to start thinking ALT is not the way to refer.
Yeah.
The other thing, can I entice the primary care to increase their income by doing something that they would like to do? And, and especially if elastography becomes readily available. Still,
Thanks,
whatever they do, they come to us as specialists. We do the further studies to really stage the disease.
Thank you. Those are very important points. We have 5 more minutes left before your break, so I don't want to be between
Okay,
you and then
don't
the
wanna
coffee. We'll have
exactly.
Anne finish the case,
All
and then
right.
we can have a few more comments.
So sequential use of non-invasive testing helps to narrow that gray zone, right? The indeterminate zone. So in Elena's case, we have some options. So MR elastography in Arizona, not an option for me because I can't get it paid for. I know you're a huge proponent and I would love to be able to order it, but not yet. Maybe someday, hopefully. Ultrasound elastography, I think we've had, from my perspective, it overstates fibrosis in obese patients. If their BMI is over 35, who knows? So then we have FibroScan, readily available, right? So that's definitely an option. If you breathe in my office, you get a FibroScan. Like it just goes hand in hand. The FibroSure, you guys can comment on that. We have LiverFast that's coming up with fibrognostics. That's a different kind of variation on that. And the ELF test, which right now FDA approved, but not commercially available. You can order it, but you have to pay, your practice has to pay ahead of time. And depending on how many you order a month, it can lower the price, but it's still, you're paying up front for a test that I'm not sure how to interpret yet. So I'll let you guys
Let's go to the next slide, and then
Okay.
maybe we can make a comment about both of them. And just let's...
So sure, just some of the advantages and disadvantages of the imaging, non-invasive imaging that we have available. I think I sort of mentioned some of that. Transient elastography is fairly readily available. It's definitely interoperator variability plays a huge role. So who's doing your FibroScan? How much experience do they have? Do we really trust the results all the time? If there's a lot of inflammatory activity going on, if the patient has ascites and that hasn't been well vetted, you may get a result that is not really what you're looking for. MRE, Dr. Lumba, you can talk about that, but I would love to use it more, but outside of clinical studies, I'm just not able to yet. And ultrasound elastography involves a referral to a radiology center or a hospital to do, and not always impressed with the results there either.
So let's just actually have just a short discussion about, now FibroScan, there is this idea that's widely available. But once you're past, the large cities and if you go to sort of some of the areas, rural areas, no one has a FibroScan or even heard of it. So what do we do? I mean, the FibroSure, do you guys order FibroSure for fatty liver?
Not me.
I've never done it.
Not me.
How about you, Rohit? No? ELF testing, if it became available, would you use it instead of FibroScan or in addition to FibroScan? Mazen.
I think we have very good evidence now. This is becoming kind of art. And I think we have strong evidence that we need to use a combination. In my mind, the only test probably that does not need combination is the MRE, because it's cross-sectionally is very solid in assessing fibrosis. You talked eloquently about the FibroScan. When it's less than 6.5, I think everyone in this room is confident that your patient does not have fibrosis. But when it's 14, all of us question if the patient has cirrhosis or not. So this is when the combination or sequential testing start, or even liver biopsy. If the FibroScan is in my clinic, if it's 14, I do MRE. A lot of people don't do that. But it's becoming kind of like a combination of tests and making clinical sense. So yeah, I mean, ELF eventually will become helpful. Let's say FibroScan is giving me 14, I can get ELF and start making clinical sense. So the combination will be the usual in our clinics eventually.
I think the way to think about any test is if you can sample a property of that organ, then that's better. So serum-based or blood tests are easier to do, but they're giving you the whole body profile. So understanding that ELF includes hyaluronic acid. Hyaluronic acid can be made by different organs, including joints. So, in a certain diabetic, you may have elevations in hyaluronic acid, irrespective of whether you have significant fibrosis in your liver or not. So I think I'm always interested in the physical properties of the organ here at liver. So a FibroScan would be higher level evidence to me than a blood test, unless the blood test is very specific and only induced by a liver problem.
Thank you. Let's finish up the, I think we're running out of time.
Yep.
And any additional comments or other things you have?
So not surprisingly, Elena has a FibroScan, and she has potentially advanced disease. So Dr. Harrison nailed it. This lady has NASH, and she may have advanced disease. Do you trust the FibroScan result in this patient? Since we started out with not a ton of evidence pointing towards advanced fibrosis.
So that's a great example that all of us is this, if you screen her for clinical trial, she might come F1 or F0. And then you do the fast score, it will depend a lot on the AST. So this is a patient that in your clinic, from the setting you told me so far, she needs a liver biopsy. And I think in Rohit, in my head, we're probably gonna do MRE. Honestly, I think this patient is F1. That's what she's gonna turn eventually. Stephen.
So last comment from Stephen.
So, Mason, you made a good point, because the true positivity of what that FibroScan KPA is questionable. However, we've mined a lot of our clinical trial data pretty extensively, and when you put an AST of 51 with a KPA of 10.1 and her other metabolic risk factors, the odds of this patient being an F2 or 3 is actually pretty good.
Sure.
I agree with
Point well
Stephen.
taken.
I think
Point
that's
well
actually a good point, Stephen. I think putting in the context of other things, I think we have this. And we're going to talk about some of the issues on this slide in the next case presentation, which has to do with treatment and management. But I thank you all for staying for a few more minutes and listening to these experts about this case. We'll take about 10-minute break and come back at 10 o'clock, maybe 10:05. We'll give you 5 extra minutes, and we'll start again with the presentations. Thank you.
Thank you.
Thanks, everybody.
visiting professor of hepatology at Radcliffe Department of Medicine in Oxford. He is truly a champion of NAFLD and does a lot of clinical trials in NASH. And there's no one better than Stephen to give a talk on treatment endpoint, clinical versus regulatory endpoints for non-alcoholic steatohepatitis. I'm going to also ask Stephen to take over the next case presentation, which is going to be around 11:30. He is going to moderate and lead with Ann Moore. Stephen, welcome.
Well, thank you, Zubair and CLDF, the organizers. What a wonderful venue. For those of you that cannot be here, you're missing out. So like Mason, I have stage fright. I haven't been on a podium in 15 months. I've done a lot of Zoom calls in pajamas and a coat. So now I had to put the real pants on and step up and be a big boy. But my challenge is in the next 19 minutes to zip through treatment endpoints. And I'm really going to build on what you heard already this morning from the wonderful talks that we've had. You may see some similar slides. I'll try to give a slightly different angle on that, but also it'll help me get through the presentation a bit quicker. So here are my disclosures. And I want to start off with this data. So this really hits at what Zubair alluded to in his first presentation. And it's a comparison of two studies that I did about 10 years apart. They both represent a middle-aged cohort of Americans in San Antonio, Texas, that presented for routine colon cancer screening. These patients had no idea that they had liver disease. In fact, if they had liver disease of any type, they were excluded to include a known history of fatty liver. On the left, you see liver biopsy proven NASH. So if they had abnormal liver enzymes, abnormal ultrasound, we did a liver biopsy, and the prevalence of NASH back then in a middle-aged cohort of asymptomatic patients was 12%. Severe fibrosis, 2.7. Fast forward 10 years, same patient population, different cohort, you see a slightly higher prevalence of NASH, but an almost doubling of significant to severe fibrosis. And that is consistent with the modeling that Zubair has shown. This is real-world data. This is prospective liver biopsy-driven data. And I think it speaks to really the crux of the problem that we're faced with. So with that, I've been tasked with two challenges: regulatory trial endpoints with a focus on FDA consideration and clinical trial endpoints. So we'll start first with the regulatory endpoints. So we have been given this document, the non-cirrhotic non-alcoholic steatohepatitis with liver fibrosis, developing drugs for treatment guidance from the FDA. Focus is on serious conditions. We think NASH is a serious condition. We need to look for an advantage over available therapy in our clinical drug development trials. And it is okay to have a surrogate endpoint that's reasonably likely to predict a clinical benefit. And that benefit is how a patient feels, functions, or survives. It has been deemed appropriate to have liver histology as a surrogate endpoint to support accelerated approval. We are not yet at the point of having a surrogate of a surrogate, meaning an imaging-based or a blood-based biomarker to replace liver biopsy, although the hope is we're transitioning to that. So here are the problems in drug development for NASH: gradual slow progression of disease, potential lifelong therapy is needed, and comorbidities that may shorten a patient's life before liver disease actually claims them. So focusing on the liver, not on the heart, not on the kidneys, not on something else. When we look at liver, we know that fibrosis actually is what's linked to a lower likelihood of survival. It doesn't mean NASH is not the main driver of fibrosis, but when we look at it very pragmatically, it boils down to the more scar you have, the higher the likelihood of having an outcome. So having that in mind, we can boil this down to outcomes being clinical, metabolic, inflammatory, or fibrotic, and we can look at the hard endpoints I have listed here. Now, when we break that down into its, we run that to ground and unpack what that means. For the purposes of clinical trials, in early phase studies, we can look at surrogate endpoints to predict a hard endpoint. So if we're looking at clinical, we can use VCTE or MRI or wet biomarkers. Those wet biomarkers are both
fibrotic-based and non-fibrotic-based, meaning Pro-C3, Fib4, NAFLD fibrosis score, and ELF. When we're looking for metabolic changes, meaning reduction in liver fat, improvement in insulin resistance, impact on lipids, et cetera, we have ways to measure that non-invasively, and I have those listed here. So for the purposes of early clinical trial development, I'm focusing on 2A type studies. We can look at ALT, and Rohit's shown this very elegantly already, and we can look at MRI-PDFF. So he explained to us very nicely how these numbers were derived. 17 unit per liter reduction predicted histologic response in ALT, and a 30% relative reduction predicted response based on MRI. So having that, in large clinical trials that include paired liver biopsies, surrogate endpoints can be validated against these histologic endpoints. And we know already, as Rohit's shown us, that MRI-PDFF can be correlated to histologic response. So what are the phase 2b/3 registration trial regulatory endpoints? There are two: NASH resolution and fibrosis improvement. You see those listed here. For full approval, however, we need to show progression to cirrhosis in a placebo-controlled study or progression to clinical endpoints, and you see those listed here: hepatic decompensation, liver transplant, all-cause mortality, MELD of 15 or higher. Now, when we focus on cirrhotic trials, what we're beginning to see in drug development in NASH is trials focused on non-cirrhotic NASH and trials focused on cirrhotic NASH. And the non-invasive tests that link to those are likely to be different. In fact, I predict they will be different. But based on the endpoints that the FDA has spoken to, we can look at improvement of fibrosis. In other words, regression of cirrhosis to an F3, an F2, something like that. We can look at progression to clinical events. Others proposed by sponsor might be prevention of progression to disease, right? So you have a you have a cirrhotic that's well compensated and you're wanting to prevent progression as listed above. Now, there's an alternative approach that was recently presented by the FDA at their webinar back in January. And Rohit's also been involved with this, I believe. Number one would be to take a standard phase 3 randomized double-blind placebo-controlled trial for F2 and F3 NASH. This is a very typical phase 3 trial. You've seen this done with obeticholic acid, with elafibranor, with resmetirom, and in addition to that trial, you're going to do a parallel phase 3 randomized double-blind placebo-controlled trial for compensated cirrhosis secondary to NASH. The first trial gets you submission of marketing application, and the second trial, if meeting its endpoint, gets you full approval for NASH with fibrosis, including compensated cirrhotics. Now, the advantage is no need for phase 4 confirmatory study when conducting phase 3 trials. There's more information to come on this. We have an endpoint conference by the AASLD that Rohit and I are putting together that'll be in June, and the FDA has agreed to speak at that meeting and provide more clarity on this particular topic. So what about these biomarkers? And we've spoken about them a bit already, and this could be PDFF, it could be ALT, gamma GT, ELF, Pro-C3, and this graph, I think, this table illustrates a couple things that are important. Number one, it doesn't matter what drug you're studying, and you see those listed on the left. ALT tends to be a predictor of both NASH resolution and fibrosis improvement across the board. It spans the waterfront. It's pleiotropic. It covers all of the drugs that are being studied. So if you were to hang your hat on one biomarker, improvement in ALT reaching a certain threshold is actually relatively predictive of response. Now, the others you see listed here may be more mechanism specific. And so when we look at ALT across the drugs that are furthest along in development, I have those listed here broken down into leading metabolic mechanisms. You see the FXR, the GLP-1, the PPAR, and the thyroid hormone receptor beta drug. And then I have the FGFs. You can also break this down into injectables versus non-injectables. However, you see it done this way, and really the focus is on ALT. And here what I'm trying to highlight is that the drugs that are hitting more than 17 unit per liter reduction are those you see listed here that for the most part have shown a histopathologic benefit already. Exceptions to that would be pegvelformin you see there, as well as Genentech and 89bio that are still waiting on their first histopathology results. But based on what we see, you could predict that there will be some likelihood of a positive impact for those patients in those trials. And Rohit's already shown this, illustrating the ALT reduction with the beta-cholic acid over time relative to, time over relative to ALT reduction with the Regenerate study. And that just, again, illustrates the point. So the Regenerate trial has read out. It showed a benefit on fibrosis improvement that met its surrogate endpoint, and you see also a nice drop in ALT. I want to shift gears a little bit and talk about CT1. We haven't spent a lot of time on multiparametric MRI, but I just want to illustrate a couple ways that that is still hanging around and still may provide some benefit. So in panel A, you see a patient that has a NAFLD activity score of 1. The CT1 is on the bottom left. You see a dark green liver. It's 648 milliseconds. We know from the data that around 830 milliseconds for multiparametric MRI defines a NASH population. So this is not a NASH patient. It correlates well with the histology. The PDFF there is 6.5%. So in panel B, you see 830 milliseconds. So this is a patient just beginning to have NASH. The PDFF is 17%. And in panel C, you see an orange liver there. The NAS is 5, the CT1 is 916, and the PDFF is 18.5%. So having that in mind, what we can show you here is data recently published in Frontiers in Endocrinology that a CT1 difference of 88 milliseconds is related to a 2-point improvement in the NAFLD activity score and a 1-point decrease in ballooning. Also, a relative difference of 21% in PDFF has been linked to a 2-point improvement in the NAFLD activity score as well as with ballooning. So here's an example of this put to real life. So this is a beta-cholic acid, 25 milligram, and on the top panel, you can see this is following them over time. So the top is OCA 25, on the bottom is placebo. And if you look at baseline, we'll start with placebo, bottom left. At baseline, this patient had very active NASH with fibrosis. The CT1 was 1,072 milliseconds. Over time, across 18 months, it didn't change. The final CT1 was 1,000 milliseconds. And if you look in the table right to the right of that, and you look at those patients that had high CT1 scores at baseline, 98% of them did, and at the end of the trial, 97% of them still did. Alternatively, if we look at OCA on the top, at baseline, this patient had a very active NASH profile of 920 milliseconds, dropping to under 800 by the time the trial ended. But maybe more importantly, we can use CT1 to illustrate what happened at baseline. 73% of the cohort had high CT1 scores. At month 18, only less than 1% did. So it's just another way of looking at how the drug is impacting the liver more holistically than what you see on a liver biopsy. So shifting gears to PDFF, this has been mentioned already. I want to specifically focus on the implications of PDFF in drug development. And here, this is an illustration of resmetirom. And on the vertical axis, you see the percent response, and the dark bars represent a greater than 50% PDFF response. The purple is greater than 30%, and then the light purple is a PDFF non-responder. And you see on the horizontal axis, NASH resolution, fibrosis reduction, and then both NASH resolution and fibrosis reduction, illustrating here that the more fat loss you have, the higher the probability of NASH resolution, the higher the probability of fibrosis reduction, and the higher the probability of hitting both NASH resolution and fibrosis reduction. This is illustrated more so with a different mechanism, an FGF19 drug called aldafermin. And in this particular graph on the left, you see amongst F3 patients, the fibrosis improvement of at least one stage without worsening of NASH after 24 weeks of treatment. It was 0% in placebo, 30% in aldafermin. On the right, if you enhanced the F3 population by saying these F3 patients actually had at least a 30% reduction in PDFF, now we see that 46% of those patients actually had a 1-point improvement in fibrosis stage, illustrating again that an improvement in MRI-PDFF can not only predict NASH resolution, but here's another illustration, small study of where it's impacting fibrosis as well. Moving to MRE, MR elastography, Mazen's talked about this, Rohit has as well. This is data published by Alina Allen's group looking at liver stiffness by MR elastography, predicting future cirrhosis, decompensation, and death. And for every 1 kPa increase in liver stiffness by MRE, non-cirrhotic NAFLD subjects are 3 times more likely to develop cirrhosis. And then when we shift to cirrhosis, for each 1 kPa increase in stiffness, subjects with NASH cirrhosis are 32% more likely to develop decompensation. So I mentioned earlier that we're likely seeing a paradigm shift from a focus being on just NASH trials to focus being on non-cirrhotic NASH trials and cirrhotic NASH trials. And I will stand here and tell you I firmly believe that MR elastography will become very rapidly the PDFF for non-cirrhotic trials, as this is for cirrhotic trials, based on the data that Mazen's worked on, Rohit and Alina Allen has shown here. So ELF, we've talked about that as well. This slide's been shown already. 9.76 cutoff predicting progression to cirrhosis, 11.3 predicting decompensation. This comes from work with the simtuzumab trials. And then PRO-C3. We haven't talked a lot about PRO-C3 yet, so I'm going to introduce that to you now. This is a marker of fibrogenesis. And you can see here in work that Arun Sanyal published just recently that PRO-C3 values in normal patients around 9.5 to 10, NAFLD patients with no fibrosis, in this illustration around 11. The numbers are small if you look at the n sizes, but the point I want to drive home is that there is a nice linear relationship with PRO-C3 and fibrosis stage, with one exception. Once you get to F4, it tends to plateau out. So the amount of new scar being laid down in a cirrhotic patient is not as much as, say, or is not more than, say, an F3 patient. You see that illustrated here, where the two values are about the same. Now, maybe the most important part of this slide I want to drive home to you is what we haven't known is what's the magnitude of effect change relative to PRO-C3 in drug development. We talked about ALT being 17 unit per liter reduction. We talked about PDFF being 30%. Well, in this illustration, again, small numbers, single-centered study at VCU, a 20% relative drop in PRO-C3 was actually predictive of at least a 1-stage improvement in fibrosis. We can add to that recent work by Ken Kuzi, published in Diabetes Care, focusing his work on pioglitazone, where he showed that a 4-unit change in PRO-C3 was linked to a 2-stage improvement in fibrosis. And this illustrates work that actually Mary Ranella put together and showed at NASH-TAG, and I'm stealing it from her here, but she's in the audience, so maybe she gives me the nod that it's okay to show it. But essentially, this is aldafermin, efruxifermin, lanifibranor, and resmetirom. All have measured PRO-C3 and all have shown positive changes relative to that. And now in the data I've shown you previously, you can begin to infer that roughly a 4-unit change might be suggestive of fibrosis improvement or a 20% relative change. Now, these are early days. This is more provocative in conversation. We need to prove that in larger trials. But I think we're headed that way. Now, for cirrhosis, we do know that regression is associated with improvement in clinical outcomes, which is one of the endpoints for a cirrhotic NASH trial. And this work was put together by Arun. It's been submitted for publication. It comes from the STELLAR-4 and simtuzumab trials, showing that if you have fibrosis regression, the probability of a liver-related event drops significantly. And then finally, I want to tie in artificial intelligence. I firmly believe that we are moving in this direction to augment semi-quantitative assessment of NASH resolution and the components of NASH, as well as fibrosis. And here you see that when you apply artificial intelligence on a fully quantitative scale, that you can actually enhance the response seen by the drug. In this particular case, cilofexor and farsocostat. Now, the final point I want to make is patient-reported outcome measures. So in addition to histopathologic change, again, remember, the FDA is looking to see how drugs affect patients' function, how they feel, and how they survive. So measuring PROs is actually very important. So we have clinical outcome, which is survival. We have patient-reported outcome measures, which really speak to the patient experience. And we can measure this through health-related quality of life measures like the CLDF NASH, functional status, and worker productivity. And then finally, economic. We can measure direct cost, indirect cost, and intangible costs and get at resource utilization. So I'm going to finish up with just 3 slides that illustrate NASH development in its current landscape. This is fibrosis improvement, and we can see going from left to right, increasing across the dosing duration from 24 weeks to 78 weeks, where the field currently stands for fibrosis. Here's NASH resolution. And then finally, both NASH resolution and fibrosis improvement, which I think is the ultimate goal of trying to improve overall liver health, not just NASH resolution, but also fibrosis improvement. So in conclusion, histologic endpoints are acceptable for phase 3 registration in NASH, as they're likely to predict clinical benefit. Non-invasive tests have shown correlation with histology, and I wanted to illustrate a wide range of these non-invasive tests, and I think we're well on our way toward validating them. These tests may be used to assess therapeutic response as well, not just an outcome measure, but how well you're doing and how well you're responding to drugs. The regulatory endpoints must meet clinically meaningful criteria. Phase 3 NASH F2 and F3 trials with histologic endpoints can be performed in parallel with cirrhotic NASH trials. This is a new concept and one that the FDA will be explaining in more depth in the coming months. We do know that these non-invasive tests, while provocative, need more validation for correlation to long-term outcomes. And when we look at artificial intelligence, I'll add one point there. When we look at fully quantitative assessment of collagen and we show, say, a 40% improvement, what we don't know yet is what percent improvement in that continuous variable is linked to an outcome measure. So we still need to prove that. But thank you for your time today, and it's been an honor to present this today.
Thank you much, Stephen. This was wonderful. So our next presentation is from Naeem Al-Khoury, who is the Director of Fatty Liver Program and VP of Academic Affairs, Chief of Transplant Hepatology as Arizona Liver Health. So he didn't have to drive too far coming here. He's, again, an authority in non-alcoholic fatty liver disease. And the topic he's going to cover is basically lifestyle modification, as well as what are the current regimens that we have for treatment of non-alcoholic fatty liver disease. So Naeem, welcome. Thank you.
All right, thank you, Dr. Younossi, for the kind introduction. Thank you, CLDF, for inviting me. And welcome, everyone, to my hometown of Scottsdale. Finally, life is coming back to normal, so good to see everyone. I think most of us have received vaccination, so this is great. My task today is to talk about lifestyle modifications and the currently available regimens for NAFL. So these are the objectives. In the first part of my talk, I will discuss an update on weight loss, mainly through lifestyle modifications as the mainstay of treatment of NAFL and NASH today. And then I will discuss currently available therapeutic agents that you can utilize in your clinic today to treat patients for NASH. This is my Twitter, and we are active on TikTok. So if you want to have a laugh, please check out our TikTok account. And if you do, please follow us. We need more followers. All right. So let's talk about lifestyle management of NAFL. We are all familiar with this pyramid now, and we know that you need to achieve about 10% total body weight loss to see regression in fibrosis. But in fact, any weight loss is good weight loss in patients with NAFLD, and as little as a 3% weight loss may be associated with improvement in steatosis. This data has been generated mainly by a study conducted in Cuba, included about 300 patients, and only 10% of participants in a clinical trial were able to lose that 10% body weight. So this speaks to the fact that 90% of individuals that try to lose weight for NAFLD are not able to achieve these goals. We underutilize weight loss medications. Bariatric surgery is definitely also underutilized in the NAFLD population, but achieving that 10% is what I tell my patients in clinic. Now, when it comes to dietary modifications, everyone has an opinion. We don't have consensus. Is it fructose, which is known to be more lipogenic, or is it all carbohydrates that are bad for NAFLD? Do you go on a low-carb diet versus a low-fat diet? Is it all about calories? There's some preliminary data showing that maybe low-carb is more effective in reducing ALT compared to low-fat. Many of my patients go on keto diet, which can induce rapid weight loss. We have some data showing that it might be associated with reduction in liver fat measured by the CAP score with the FibroScan machine, maybe some reduction in liver stiffness, but we definitely need more data on the keto diet. And the latest thing that I see in my clinic is intermittent fasting, which is definitely effective in inducing weight loss, but we are lacking good data in NAFLD, and there is no histologic data that I'm aware of on intermittent fasting in terms of NASH resolution and improvement in fibrosis. The diet that we have the most data in terms of cardiovascular outcomes is the Mediterranean diet, which is my diet. It's high in monounsaturated fatty acids, PUFAs, nuts, green leafy vegetables, and I always emphasize it has to be low glycemic index Mediterranean diet. So Mediterranean does not mean pizza and pasta. It means salads and fish. And of course, it's low in saturated fats. And we have data in NAFLD looking at the Mediterranean diet. So this was a proof of concept paper published in the Journal of Hepatology a few years back, where they randomized patients to receive Mediterranean diet or a low-fat diet. They did it for 6 weeks. They did baseline testing that included measuring liver fat based on MR spectroscopy. And they also did a euglycemic clamp study to assess insulin sensitivity. They did this at baseline, and then after 6 weeks, they had a washout period, and then they flip-flopped the patients. So the ones that were on low fat went on Mediterranean diet, and they did the retesting again. And what they showed here that despite having similar weight loss, the patients on the Mediterranean diet reduced their liver fat to a greater extent than patients on low-fat diet. So this was measured by looking at the hepatic triglyceride content. They also showed that patients on the Mediterranean diet had improvement in insulin sensitivity measured by the glucose infusion rate. More recently, there was a recent paper published on the green Mediterranean diet, which has the same basic components of a regular Mediterranean diet, but they added 3 to 4 cups a day of green tea. And then they added something we call Wolffia globosa, which is manicay or duckweed. And basically, they created a green shake with duckweed that replaced dinner. And then during the day, they ate a regular Mediterranean diet, and they had to drink the tea. This Wolffia globosa has actually vitamin B12, so it's the only plant we know of that has vitamin B12. And by adding the green tea and the Wolffia globosa, they added about 800 milligrams of polyphenols to the diet. This is a flowchart showing the trial design, and briefly, they randomized 98 patients to each arm. So you had the regular Mediterranean diet, green Mediterranean diet, and then just healthy diet guidelines. And 89% of patients were able to complete the trial. And what they showed here in the first figure, figure A, that patients with Mediterranean diet and green Mediterranean diet lost more weight than individuals that went on the healthy diet guidelines. So the weight loss between the two Mediterranean diets was pretty close. But when they looked at liver fat content as measured by MRI, they showed that patients on the green Mediterranean diet lost significantly more fat from their livers compared to the regular Mediterranean diet. They show two examples here on MRI. So the first one is MED, is the regular Mediterranean diet, and this patient went from 14% liver fat to about 8%, which is significant. But look at the next patient, which is the green Mediterranean diet, started at 18%, 19%, went down to 0.8%. I mean, defatted the liver completely, and this is basically NAFLD resolution. Of course, this is, a selected case, but if this data hold in other studies, this is very impressive, and this could become part of the recommendations, is to go not on just a Mediterranean diet, but maybe include these ingredients of the green Mediterranean diet. This is a summary table looking at the different diets and their effects on different aspects of NAFLD and metabolic syndrome. I'm not going to go through the details, but you can see that we are still lacking mainly in terms of histologic data on NASH resolution and fibrosis improvement. So we need to generate more data, and we need more data on some of the new NITs and how they change in response to lifestyle changes. So when I see patients in clinic, I call it the diet wars, but every patient is attached to a diet. They think it's the best thing ever and it's going to resolve all their metabolic syndrome components. And honestly, the recommendations are very different. So plant-based diet is high in good carbohydrates, low in animal protein or no animal protein, versus the paleo diet, which is all about eating animal protein. You have intermittent fasting. And of course, my favorite is the ice cream diet. I hope, eventually we'll have enough data to support that this is the diet to go. I would be happy to be on this diet for the rest of my life, but I have serious doubts about that. In terms of physical activity, just a couple of slides. How much physical activity is needed? Do you need to run a marathon to resolve your NAFLD? And the short answer is any exercise is better than no exercise. You need to exercise one way or the other. It doesn't have to be aerobic exercise. Resistance training has benefits on NAFLD, and we have several studies. But I want to show one paper from the NASH CRN. This was 867 patients that had biopsy-proven NAFLD, and they divided them into inactive patients, and that was the majority, 54%. And then they had patients that had moderate physical activity, 20%, and patients that had vigorous physical activity, 26%. And they showed that in terms of the odds of having NASH and having advanced fibrosis, that only the patients that met the criteria for vigorous physical activity had less odds of having NASH and advanced fibrosis. So you need to push your patients. You need to tell them that I want you to be physically active. Try to aim high. I say 60 minutes, 5 times a week. I know my patients are not going to do this, but if you can get them to that vigorous physical activity threshold, I think this is where you're going to see most benefits of exercise. Of course, in real life, many of my patients have a bad knee or a bad back, and they cannot comply with this. So any exercise is better than no exercise. And this is just a summary slide on lifestyle recommendations that I give to my patients. You need to understand the severity of their disease. Do they have NAFLD? Do they have NASH? Do they have NASH cirrhosis? How much weight loss do they need to lose? Obviously, you need to lose more if you have NASH and fibrosis. I provide some dietary guidance also. Prefer not to eat any unhealthy snacks and minimal alcohol intake. Of course, for NASH cirrhosis, you have to encourage a midnight snack. Make sure they eat throughout the day. I try to increase their protein intake. I discourage intermittent fasting in patients with NASH cirrhosis. So understanding, the disease severity is very important, even for lifestyle counseling. I recommend exercise to anyone who is able, no cigarette smoking, and stress reduction via meditation or whatever, strategy they have, and good sleep hygiene. But this is the reason why weight loss does not work in the United States. So these are real food challenges that we have in Scottsdale, Arizona. And if anyone is interested, I'm happy to point you to the direction of these restaurants if it's part of the research you're doing on NASH. But I highly advise you not to eat these. But one is this 3-pound burger that if you eat in 45 minutes, they give you a t-shirt. And then we have the 72-ounce steak challenge, where you get the steak for free if you can finish it in one sitting. So, we have a long way to go, obviously, with lifestyle changes, but this is really the first step for everyone. Bariatric surgery is a very effective modality to treat NASH and fibrosis. This is data from the French group looking at biopsy at the time of surgery, biopsy 1 year later, showing NASH resolution in 85% and improvement in fibrosis. There is more follow-up data now at 5 years, and it seems like this response is sustainable. Unfortunately, bariatric surgery is not performed in many patients that actually will qualify for it. So the estimates are probably 2 to 3% of people that meet criteria for bariatric surgery end up actually receiving the surgery. But this is a very effective modality, especially for patients with significant fibrosis and NASH. Okay, so moving on to the current treatment regimens. We're talking about pharmacologic treatment here. We're all familiar with the PIVENS trial that randomized patients to pioglitazone 30 milligrams daily, vitamin E 800 units daily, or placebo. This was strictly non-diabetic patients with biopsy-proven NASH. Primary outcome was improvement in histologic features of NASH based on the NAFLD activity score. And these are the results. So if you look at resolution of NASH, not improvement in NAFLD activity score, in fact, pioglitazone met that endpoint of resolution of NASH, and that was significantly better than placebo. There was a signal also, or a trend in the vitamin E arm. But the issue has been in our clinics is that vitamin E and pioglitazones, they both have stigma. There was a meta-analysis showing a slight increase in overall mortality with vitamin E, despite including different doses and different indications. There is potentially increased risk of hemorrhagic stroke, although maybe there is improvement in atherogenic stroke. And then there was one study showing a slight increase in prostate cancer with vitamin E, although this is very debatable. But you have to kind of discuss this with your patients when you put them on vitamin E. And then pioglitazone, the main issue is weight gain, and the weight gain is real. There's potential for fluid retention and worsening heart failure. And then there is debate on increased risk of bladder cancer, and there is a bone loss effect. So that's why, vitamin E and pioglitazone, in my mind, are underutilized in our clinics. There's more data on pioglitazone in patients with prediabetes and diabetes. This is data from Ken Cusi at the University of Florida, showing that, after 18 months of treatment, these patients actually achieved the primary outcome, which is decrease in the NAFLD activity score by 2 points or more. And this was achieved in 58% with pioglitazone. The dose was 45 milligram a day, so higher than the dose we had in the PIVENS trial. And when you look at NASH resolution, approximately 50% had NASH resolution at 18 months, and this was higher than the placebo arm. So pioglitazone in patients with diabetes, especially if they are on just metformin and they're not controlled, is actually a reasonable option as long as you anticipate the weight gain and talk about other potential adverse events. We have more data on the new diabetes drugs. So this is a slide on the SGLT2 inhibitors. Data is still preliminary, but you're seeing data from the ELIFT randomized trial. This was a relatively small trial, 42 patients that received either standard diabetes care or empagliflozin, which is an SGLT2 inhibitor. And in terms of reducing liver fat on MRI-PDFF, you can see that there was significant reduction with EMPA from baseline and no significant change in the control group. And then when you look at ALT reduction, there was also significant reduction with EMPA compared to the control group. There is also data with canagliflozin, 300 milligram daily, showing reduction in liver fat based on imaging. So these agents are promising. They're easy to take. They have cardiovascular benefit. They may have a renal benefit. So I think these are promising agents. They induce modest weight loss, and they may have an effect on NAFLD. Vitamin E in advanced disease has shown some promise also. This is data from the Naga Chalasani group at Indiana University. It's a retrospective study. They looked at patients with F3, F4 fibrosis on biopsy, and they looked at patients that were receiving vitamin E versus no vitamin E, followed them for 2 years or longer, and they showed that the patients on vitamin E had better transplant-free survival and less chance of decompensating. So again, take it with a grain of salt because this is not a randomized trial, but this is promising data, and I do prescribe vitamin E to my patients with advanced fibrosis in selected situations. How about the GLP-1 agonist? This is data from the LEAN trial with liraglutide versus placebo. This was a relatively small study also, about 50 patients, but they showed significantly higher odds of NASH resolution with liraglutide compared to placebo, and there was weight loss and reduction in ALT. So this is promising. And more recently, we saw at the liver meeting a phase 2b histology trial with the semaglutide that showed that with the higher dose semaglutide, 0.4 milligram daily, there was NASH resolution in approximately 59%. So one of the highest rates we've seen in clinical trials for NASH resolution. And this was significantly better than the placebo arm. GLP-1 agonists induce robust weight loss. A couple papers were published in the New England Journal of Medicine on semaglutide and its efficacy in weight loss, even in non-diabetic patients, and they have a proven cardiovascular benefit in patients with type 2 diabetes. So good agents to consider. So when we think about, diabetes in our patients with NAFLD, I like to divide the medications into good ones and bad ones. And I think the good ones are the GLP-1 agonists, SGLT2 inhibitors, and pioglitazone. You have to look at their NAFLD benefit, the chances of them inducing hypoglycemia, and their effect on weight. And GLP-1 agonists and SGLT2 inhibitors, they have efficacy for NAFLD. They both induce weight loss, and they have a cardiovascular benefit. Compare that to metformin, DPP4 inhibitors. It seems like they have minimal efficacy on NAFLD, metformin slight weight loss. I love metformin. It may be actually protective against hepatocellular carcinoma, but efficacy-wise for NASH, it's not proven. And then you have the bad ones, and these are probably the sulfonylurea that can make you gain weight. They may induce hypoglycemia, and they may actually worsen cardiovascular outcomes. And of course, we want to avoid insulin if possible. So when you see patients with diabetes and NAFLD coming to your clinic and you look at their medications, look at their diabetes medications and see if you can optimize their diabetes management. I try not to interfere with primary care management, but I actually put it in my note and suggest changes to their diabetes management. And finally, I want to leave you with this slide from the AASLD guidelines, the 2018 guidelines, looking at what's recommended. So metformin is not recommended as treatment for NASH, but again, it may have a protective effect for hepatocellular carcinoma. Pioglitazone is recommended in patients with biopsy-proven NASH, and I see an opportunity in patients with prediabetes and diabetes. Liraglutide in 2018, we didn't have enough data to recommend the GLP-1 agonist. I suspect this is going to change in the future, especially as we have more data with semaglutide. And then vitamin E is recommended only in non-diabetics now with biopsy-proven NASH. I showed you some of the data on patients with more advanced disease, and it may have a benefit even if they have diabetes. And none of these medications are FDA approved for NASH specifically. So with this, I'm going to conclude. This is my take-home message. Try to achieve weight loss of 10% or more if you can. Try to personalize the lifestyle intervention and share different approaches with the patients and select what works for them, because that's the most important thing, is that they can stick to the diet and maintain the weight loss. But the other key message is that we do have pharmacologic treatments today that can be used in certain patients. They have issues. The efficacy is not great, but in my mind, in selected patients, they actually have a clear benefit. So try to get them on these medications. With this, thank you so much for your attention. It's been a pleasure.
Thank you very much, Naeem, for the excellent review of the current treatment options. Our next speaker is Dr. Manal Abdulmalik from Duke University School of Medicine, who's a professor of medicine there, and also a leader in NASH and leading a number of clinical trials in non-alcoholic steatohepatitis. And what Manal is going to talk about is new targets for emerging therapies in non-alcoholic steatohepatitis. Manal, welcome.
Good morning. It is, first of all, I'd like to thank Dr. Zubair Younasi, the steering committee, for the opportunity to be here. It's just such a joy to see everybody in person. This has been a fabulous meeting so far, and I have some fabulous presenters to follow. I also like to thank Focus Medical. They've done an outstanding job with the combined hybrid platform for this meeting. So I'm going to be talking about new targets for the treatment of NASH. Here are my disclosures. And I'd like to start out clearly the pathogenesis of NAFLD and NAFLD-related fibrosis is one that's complex, multiple interacting, interconnected, metabolic, inflammatory, and fibrogenic pathways that are intertwined not only with the syndrome of insulin resistance, but as well as the downstream cascade of the management of and storage of free fatty acids into triglycerides, the overwhelming ability of the mitochondria to process such triglycerides and beta oxidative stress, lipotoxicity, and associated pro-inflammatory pathways related to T-cell activation, inflammatory cytokine trafficking, the activation of hepatic stellate cells, and the interaction also with the dietary intake, the association with the gut microbiota, the downstream inflammatory pathways of cytokine-mediated inflammatory stress, and its interaction with the FGF and FXR signaling pathways. But if you were to break this down and put it simply, I think we can talk about the pathogenesis of NAFLD and NASH into three buckets, if you will: metabolic targets, anti-inflammatory targets, anti-fibrotic potential targets. So, and clearly in 20 minutes, I'm not going to have the opportunity to delve deeply and do a deep dive into the NASH landscape. But this is one depiction of this landscape. And as you could see from the outside in, the multiple compounds that are in phase 1 clinical studies, phase 2, and the dearth of compounds that have actually made it into phase 3 clinical trials to approval. But if we were to bucket these compounds, the overwhelming majority of targets in the therapeutic landscape of NAFLD and NASH are in the metabolic space. And really, when you see the targets that are in the anti-inflammatory and anti-fibrotic space, there are fewer and far between therapies in drug development and targets. Overall, the goal of treatment of NASH is to improve the metabolic drivers and metabolic abnormalities that are so intimately associated with liver injury, to decrease inflammation, to prevent, arrest, or reverse liver fibrosis. And the AASLD recommends that pharmacologic treatments aimed primarily at improving liver disease should generally be limited to those with biopsy-proven NASH and fibrosis. So we've come to learn that simple steatosis is not associated with any increased liver-related morbidity or mortality. So pharmacologic therapies are targeting those with NASH at risk for hepatic fibrosis. And ultimately, we want to prevent advanced liver disease, liver failure, liver cancer, and its associated outcomes, and improve the systemic outcomes eventually for all other all-cause related mortality. And as Stephen Harrison put it beautifully, the goal of treatment and drug development in this space is one that has been integrally put together like a puzzle and built upon itself with the ultimate goal of achieving a cure for chronic liver disease. But really, we have a huge bridge to cross because FDA approval is going to hinge on whether we can make patients feel, function, and survive better. And if we were to take a look at this very carefully, NASH resolution is the strongest predictor of hepatic fibrosis, and ultimately improving hepatic fibrosis is going to be the strongest predictor of improving morbidity and mortality and liver disease. But we cannot lose sight that such targets are as we consider the pathogenesis of NASH, yes, while they are focused on treating the liver disease, NASH is one element of a multisystemic disorder, and no target for the treatment of chronic liver disease can in any way come at the expense of increasing any other associated morbidity and mortality, for which this disease is very intimately interconnected. So we cannot consider any targets that will increase cardiovascular risk, renal disease, worsen diabetes, or induce any other systemic morbidity and mortality. And if you're to take a look at the targets, as I mentioned, we can consider them in the space of metabolism, those that improve insulin resistance and lipotoxicity, those in the space of inflammation and cell death or apoptosis that will decrease risk of progression to steatohepatitis, or even those that are anti-fibrotic. But as you can clearly depict, although I don't anticipate you're going to be able to read all these compounds with clarity, you can see the abundant shift of targets in the metabolic space, as opposed to targets that have been studied in the anti-inflammatory, or even the fewer targets that have been studied in the anti-fibrotic space. And at a quick eyes glance, you could see here those targets that are in red, who have progressed through clinical development and have unfortunately failed to achieve its primary outcome. And the current compounds that are in phase 3 clinical studies in green are bundled under the anti-metabolic space. So my goal in 20 minutes is to really give you a highlight, to highlight for you with large brushstrokes and give you the big picture of the overview of the leading targets in the space of NASH as it pertains to PPARs, GLP-1s, thyroid hormone receptor beta agonists, the steryl-CoA desaturase 1, FGF19 and 21, and FXR. But the content of my talk is going to focus on those targets with therapies in late-stage clinical trials for which we have pertinent data as it pertains to histology in NASH and as it pertains to human disease. So let's start off with the PPARs. Now, the PPARs are nuclear receptor hormones. They induce gene expression, and they are involved in multiple different tissues to ultimately optimize and optimize energy homeostasis. PPAR gamma in the adipocytes regulates adipogenesis, PPAR delta and PPAR gamma, all working on fatty acid oxidation, optimization of glycemic control, even lipid oxidation and lipid management. And as you could see here, a number of PPARs have been studied in phase 2 clinical studies, and 2 PPARs in phase 3 clinical studies. I will not talk any further about any drugs that have failed to reach any primary outcome. Elafibranor has been studied. It was a combined PPAR alpha delta compound and failed to reach any evidence of resolution of NASH and will not be discussed further in my talk. And we'll focus on lanfibranor and its role in the therapeutic landscape. Lanfibranor is a pan-PPAR, and it was studied in the context of what was coined the NATIVE trial. This was a 24-week phase 2b study of 247 patients with biopsy-proven NASH, and the intervention evaluated placebo versus lanfibranor at a dose of 800 and 1,200 milligrams daily. The safety of lanfibranor was generally in keeping with what was otherwise known about PPARs, and specifically PPAR gamma. The intent to treat primary analysis endpoint was a greater than 2-point improvement in the NASH activity score as defined by the SAF score. The SAF score weighs specifically ballooning and necroinflammation into its score, and thus lends an enrichment for more severe NASH. It does not consider steatosis grade as part of its scoring system. So an improvement in 2 points in the SAF scoring system without worsening of hepatic fibrosis at 24 weeks. And as you could see, lanifibranor increased the proportion of patients who had an improvement in NASH without worsening of fibrosis, and was statistically significant at the dose of 1,200 milligrams daily. Further, the secondary outcome endpoint, which is an improvement in fibrosis without worsening of NASH, was also achieved with lanifibranor at 1,200 milligrams compared to placebo. So this was the first oral compound as a PPAR to reach the dual composite surrogate endpoint of improvement in NASH without worsening of fibrosis and improvement in fibrosis without worsening of NASH. And we'll be seeing this move forward into a phase 3 study. What about the metabolic effects of GLP-1 receptor agonists? Well, these are highly pleiotropic compounds that have multiple effects on metabolism. Not only do they decrease increase satiety, but they are cardioprotective. They optimize muscle insulin resistance, have been shown to increase beta cell function, and will induce both weight loss and optimize glycemic control. And as Naeem pointed out, this has been studied both with liraglutide and semaglutide. Multiple GLP-1s have been evaluated in phase 2 studies, but my focus is going to share with you the results of the phase 3. I will not be able to, in the scope of the talk, give you the deep dive that I anticipate Steve Harrison is going to share with us tomorrow. But the semaglutide results for NASH was reported in the New England Journal of Medicine by Dr. Newsom last fall in October. This was a 72-week trial, phase 2 study of 320 patients with NASH ranging in fibrosis from stage 1 to 3. The intervention was placebo versus semaglutide 0.1, 0.2 versus 0.4 milligrams subcutaneously daily, and the primary outcome was resolution of NASH without worsening of fibrosis. And Naeem has pointed out, semaglutide at all the doses studied reached the primary outcome of NASH resolution with the highest proportion of patients in the 0.4 milligram treatment arm. The primary endpoint was met for NASH resolution, but unfortunately not met for fibrosis regression. The safety of GLP-1s in the space of NASH is in keeping with what we know about GLP-1s in other indication areas such as diabetes or obesity, and the common adverse side effects were comparable between semaglutide and liraglutide and predominantly gastrointestinal in nature early after initiation of therapy. What about thyroid hormone receptor beta selective agonists? Now, thyroid hormone receptor beta selective agonists have very good biological rationale for the use in the treatment of NASH. We know that many patients with NASH have overt or even subclinical hypothyroidism, and thyroid hormone receptor beta is present in the liver selectively and can optimize not only heart contractility, but also the partitioning and mobilization and storage of fat from the hepatocyte. The compound that's been evaluated in phase 2 is the Viking compound, VK2809, and the leading compound in current phase 3 clinical studies is resmetirom. And as has been shared briefly, resmetirom was studied in a 16-week phase 2 trial and is currently in a phase 3 study in patients with NAFLD and NASH, fibrosis stage 1 to 3. The intervention was resmetirom as high as 80 milligrams per day compared to placebo, with the primary endpoint being a change in baseline in quantitative liver fat at 12 and 36 weeks. And the safety endpoint demonstrated that it had a very excellent safety profile. And as you could see here in the left-hand graphic, there was a prominent dose-dependent effect on improvement in quantitative liver fat with the maximum dose of resmetirom. And for those patients who achieved greater than a 30% reduction in MRPDFF and underwent a liver biopsy, there was nearly 50 to 60% resolution in steatohepatitis. On the far right-hand side of the slide, you'll see a incremental improvement in liver aminotransferases and what appears to be a very favorable cardiometabolic lipid profile with an improvement in atherogenic lipids, which is a plus. Steryl-CoA desaturase, this is actually a target. When we have steryl-CoA desaturase, we convert unsaturated fatty acids into mono unsaturated fatty acids, and this target actually induces storage of lipids in hepatocytes. However, if it's blocked, and the compound that is able to block steryl-CoA desaturases, or SCID1, is aramicol. When it's blocked, not only do we decrease the storage of fat in hepatocytes, but we also increase PPAR gamma, and in utilizing this pathway can have an effect also on lipids and on stellate cells and reduce fibrogenesis. And aramicol currently is in phase 3 clinical study. A beautiful review paper was just published by Dr. Friedman's group in Journal of Hepatology Reports just last year. So the ARREST study looked at key outcomes at 52 weeks, and this study was a phase 2b trial of 247 participants with biopsy-proven NASH who had a quantitative MR PDFF of at least 5.5% or higher. The intervention randomization was in a 2-to-1 randomization to aramicol 400 milligrams daily versus 600 milligrams daily versus placebo, with the primary endpoint being a change in liver fat at 52 weeks by MRPDFF. The safety of aramicol was excellent, with no difference in adverse events from aramicol to placebo. And as you could see here in the left-hand panel, there was a dose-dependent increase in fat reduction by MRPDFF. And in those patients who underwent biopsy, a dose-dependent increase in NASH resolution without worsening of fibrosis. What about fibroblast growth factor 19 and 21? Both these compounds work on beta-cathol, the FGFR1C target, and FGF19 works on FGFR4, and using these targets improve insulin sensitivity, reduce hepatic steatosis, and reduce and redeem lipotoxicity, and thus can reduce steatohepatitis and fibrogenesis. Aldafermin is currently in late phase 2 studies, and FGF1 agonists have been studied, and I'll be just highlighting efruxifermin. So aldafermin was studied in patients with biopsy-proven NASH, stage 1 to 3, by NASH CRN criteria, and those that had a MRPDFF of at least 8%, the primary outcome was a change from baseline in the absolute liver fat content by MRPDFF at week 24. And the secondary and exploratory endpoints were biochemical assessments of improvement and change. Rosuvastatin was utilized to mitigate the lipid effect, but as you can see here, 38% compared to placebo reached fibrosis improvement without worsening of NASH. 24% compared to 9 reached resolution of NASH without worsening of fibrosis. And when you take a look at the composite endpoint, no patient in the placebo reached that endpoint, but 22% reached the endpoint of NASH resolution and fibrosis regression. Efruxifermin is currently in phase 2 studies. This evaluated 80 patients with biopsy-proven NASH stage 1 to 3 with a liver fat content of greater than 10%, randomized in a 1-to-1-to-1 to 25, 50, or 70 milligrams. And as you could see, the study design was a little unique, as only liver biopsies were done in those patients who achieved a 30% reduction in MRPDFF. So as you can see, almost 70 to 75% of patients with efruxifermin achieved greater than 30% reduction in MRPDFF compared to placebo. And this was associated with NASH resolution in a majority of patients, as well as an improvement in fibrosis regression. And so more will be told with efruxifermin. FXR agonists, unique targets, they decrease bile acid synthesis, increase bile acid conjugation, decrease lipogenesis, decrease gluconeogenesis, and can decrease the bacterial translocation, multiple compounds in phase 2 clinical studies. But obeticholic acid has been evaluated in phase 3 in the Regenerate study. This has included over 1,900 patients in the interim analysis that was performed at 18 months with a 1-to-1-to-1 randomization of obeticholic acid, 10 or 25 milligrams versus placebo. And as you could see, 23% versus 12%, only a delta of 11% had an improvement in the primary outcome of fibrosis improvement, but no improvement in NASH. So recent disappointments in the emerging therapeutic landscape of NASH. We've had several phase 3 studies fail to reach the primary endpoint. Elafibranor had a high placebo response rate. Cenicriviroc failed to reach its primary endpoint of fibrosis improvement. And obeticholic acid, while it achieved the primary endpoint of fibrosis, due to the increased lipid signal, has received a clinical hold, and the FDA is awaiting additional data by which to render an opinion about its approval. So the future landscape of NASH therapeutics is robust. As a segue to Dr. Scott Friedman's talk, I could say that I do believe the future is going to be in combination therapy. And to conclude, multiple treatments that interrupt the pathophysiologic properties of NASH are in development. There are no FDA-approved drugs. Only one drug, which is obeticholic acid, is under FDA new drug application review. The landscape of emerging therapies for NASH will be targeting metabolic risk factors to improve NASH, which will hopefully translate into an effective halting or delaying time to fibrosis progression, and that combination therapy using drugs in different mechanisms of action is the future. Of course, there are many people to thank for this therapeutic landscape. Thank you.
So the last talk in the series of sort of treatment is from Dr. Scott Friedman, who is really a giant in the field of hepatology. As you know him as one of the leaders of fibrosis, not only NASH, but all types of fibrosis. Scott is the Dean for Therapeutics Discovery and also Chief of Division of Liver Diseases at Mount Sinai. He has been really a pioneer in the area of fibrosis as well as antifibrotics. Scott, welcome. Thank you.
Many thanks, Ober. I'm really delighted to be here. This, like many of you, is my first in-person lecture in 14 months. It's also the first time I've worn a pair of leather shoes in 14 months. I've been wearing rubber Merrells for sitting at home, so it's a very exciting day for me. The previous speakers really laid out beautifully a lot of the concepts, so I'm going to really focus mostly on some of the new elements while reviewing a little bit of the data you've already heard in a slightly different context. These are my disclosures. So first of all, Zubair actually put me to work. I hadn't prepared to talk on this topic, and like often, you don't really understand a topic until you're asked to teach someone else about it. So I found this a really great exercise and appreciate the opportunity. So why do we need combination therapies? I think Manal just laid that out very well. The efficacy of single drugs has been limited and disappointing, and we know the list of high-profile failures. We don't know if obeticholic acid is yet a success or a failure, but certainly a lot of effort has been for naught in terms of yielding FDA approval. And so combinations may do at least two things. One, they may enhance efficacy, and I'll emphasize why that's critical first, but also they may create synergistic effects, or they may capture more patients. If we believe or we conceive of the possibility that NASH is not a single disease with a single seminal pathway in every patient, it may well be that we're basically hedging our bets by capturing more targets some of which may be more important in different patients than others. So this begs the question of why has it been so hard to treat NASH? The animal studies are always so hopeful and optimistic, and the efficacy in human trials distills down to a much lower effect. I don't have a lot of time to talk about it, but part of these ideas are encapsulated in a review that Vlad Ratsiu and I wrote for Gastro last year. So on the animal model side, animal models, as I said, are more optimistic in predicting efficacy. And without time to go into detail, I would refer you to two beautiful papers from Barbara Ehrman and her group over a 2-year period in Science and in Cell that underscore the potential importance of the microbiome in general, and the fact that in animal models, we rely on inbred mice with a very simple microbiome, which may distort the interpretation of efficacy or enhance the efficacy compared to humans who are, of course, outbred. There's sometimes insufficient evidence of target engagement, even in animal models, and often inadequate evidence that the target drives the disease in humans. In other words, we know something goes up or goes down, we know we can antagonize it, or we think we can antagonize it, and yet doing so really has no impact because we're not really convinced that the target is directly driving disease pathogenesis. On the clinical side, I'll reemphasize a point I just made, which is that we may be looking at a complex disease that has multiple drivers and an unclear hierarchy of causality. Put simply, we don't know what the Achilles heel is for this disease. It may not be the same in all patients. And so we may be treating epiphenomena or downstream consequences of a single upstream or several upstream drivers. We've heard a lot about the high placebo response. There are lots of potential reasons. I think Stephen, Rohit, others here have done a fantastic job at trying to enrich in trials to avoid a placebo response. I can tell you much more than I. We've also identified a high false discovery rate in phase 2 trials. It's also not clear how long you need to treat to improve fibrosis, whether every mechanism that improves fibrosis requires the same duration of therapy. And again, there may be multiple subtypes of NASH, not all of which are responsive to the same mechanism of action. So you saw similar slides from Manal and others. This is from a consulting group, Back Bay Advisors. This is in the public domain. They highlighted the drugs currently in phase 2 and 3. In particular, if you were to add this up, there are 73 drugs in phase 2. There are 9 drugs in phase 3. There are no approved drugs. So clearly, we need to do better, and I think we will. You saw a little bit of this diagram from Manal. It really illustrates the different points of attack that we think about. It doesn't include the microbiome, which I think is extremely important in NASH. But for liver-focused therapies, it includes drugs that somehow attenuate fat accumulation in the liver, improve glucose homeostasis, are healthy or improve the state of oxidant stress or mitochondrial damage. There are other targets that are considered anti-inflammatory. These are some of the targets in phase 2 and phase 3 trials organized conceptually. Then, of course, near and dear to my heart are potential antifibrotic therapies. Thanks to Stephen and Mike, I had the chance to review integrin antagonists as one of those at the recent NASH-TAG meeting. It was another new topic for me that I enjoyed putting together. So the question is, which of these do you target and how do you combine them? Well, I'm a little disappointed to admit that the current approach to combinations is really empiric and pragmatic rather than data-driven. Rohit and I were actually on an email this morning with an unnamed commercial sponsor who suggested that maybe we should add their drug to another drug because that will allow them to improve the pricing of that combination. Those are the kinds of thinkings that make me crazy. I think it's really has to be data and scientifically driven. So what do we do now, or what do companies do? Well, they say, well, I've got 2 drugs that have separate targets or mechanisms of action. We own both drugs, or we can establish a strategic partnership with a second company and basically consider a choice that's based on complementary mechanisms, at least through a hand-waving mechanism. So you might say a company has 2 assets in-house or a strategic partner. Let's combine a metabolic target with an antifibrotic target. Let's combine a metabolic target with an anti-inflammatory target, et cetera, an anti-inflammatory, the antifibrotic. You get the idea. But these are really not data-driven, and there's no evidence for synergy. And the little data that we have so far from combination trials suggests that the current approach is not really very effective. One approach that we might consider is the following, and this is my own conception, but it won't surprise anybody. You know, there are growing culture and in vitro models that are extremely powerful. One of the most appealing is now a human liver-derived NASH organoid. This was described by Takebe and colleagues from the University of Cincinnati. You can literally recapitulate all the cells in a NASH liver. The organoids respond very similar to human tissues or human livers. Grow them in culture, and then do high-throughput screening, either with known compounds at different doses or screening unknown compounds with a very simple readout and say, how does the transcriptome change in response to these single drugs? How does the collagen secretion change in response to that using an ELISA? You could then take that first drug shown here in white and blue, add on a second library of compounds in the same high-throughput assay, and look for synergistic activity of the combination. And we keep talking about synergism, but to remind ourselves, synergism means effects that are not additive, effects that are out of proportion to the single efficacy, and we're nowhere near that in the limited combination trial data that we've generated so far. If the drugs are both, if the drugs that are found in this candidate combination are both safe and already used in humans, you can actually go directly to human combination trials, provided that each one is efficacious in its own right, or more likely, if there are new combinations or one component of the combination is new, animal studies would be required. And again, here, the mouse data would really have to account for the growing appreciation that mice are much more, I would say, optimistic in predicting drug efficacy than humans. Another point that was made very nicely by Naeem and others is, and particularly Steve, is the hopeless reliance on primitive evaluation of biopsy data by well-meaning but limited pathologists, and limited not because they're limited as individuals, but because the nature of what they're measuring is semi-quantitative and limited. And this issue came up in the FDA phone conference that I think Stephen alluded to from January, where the FDA individuals asked, well, what about digital pathology, AI-based learning methods? And the response was, that's really up to you guys in the academic sector to validate that one or more of these AI-based methods for extracting more data from a liver biopsy is actually as useful or more useful in predicting clinical outcomes. So it's on us in combination or in partnership with commercial sponsors. So this is an image from one of those companies, PharmaNest. The CEO, Matthew Petitjean, shared it with me. The area of interest shown in black and the inset is now highlighted. It's colorized, and you can literally capture all the different elements using different colorization, and of course, quantify them to a T using computer-based imaging. And you get these kinds of readouts where you can measure fiber length, fat content, distribution of fat, et cetera. Steve Harrison in his phase 2 trial with resmetirom, I think, used second harmonic generation. It was, in my view, a step in the right direction, but of course it's incumbent upon all of us, whether in single or combination trials, to actually translate these more subtle quantitative changes in the biopsy as predictive of clinical events without having to rely on staging and grading in the most primitive way. Clearly, you've heard all this already, so I'll go through this very quickly. This is from a review from Jean-François Dufour that suggests that single therapies are showing some promise. Interestingly, the pioglitazone looks most promising in terms of NASH resolution. In terms of an antifibrotic effect, these are all modest, and I'll underscore that again with data that's similar to what you've already seen. So promising single therapies that are at least in advanced phase trials are obeticholic acid instead of semaglutide, as well as bariatric surgery, which we haven't really mentioned so far. So you've seen this data in other forms. This is the obeticholic acid regenerate trial. There are a couple of points that are still worth making, even though you heard about this. First, you heard that there was an effect on fibrosis, but no effect on NASH resolution. We don't know which is better. Probably, I guess, fibrosis improvement is better, since that's the most proximate predictor of clinical events. But I like to make a different point, with all due respect to Intercept, which is even at a high dose, there was a 23% improvement, or I should say 23% of the patients improved. That is so wimpy. In what we would consider effective drugs, we wouldn't be satisfied treating hypertension and only affecting an improvement in 23% of patients. So admittedly, this is the best we've done, but it shows how much further we have to go. if we're going to achieve response rates that are approximating what we expect to see in treatment of more well-established diseases like hypertension or hypertriglyceridemia. Similarly, the semaglutide data, which you just heard all about, showed a marked improvement in NASH resolution, but it showed no impact on fibrosis improvement, and we can't really explain that. Are there going to be patients who can improve NASH without fibrosis improvement, or is it just a matter of not waiting long enough? Is all NASH resolution the same, or is NASH resolution histologically dependent on what the drivers are in that individual patient? So for example, if there, and I believe there probably are, evanescent, hard to measure lipotoxic species that are critically driving the disease, maybe not every mechanism of therapy that resolves NASH removes those lipotoxic mediators. So I think we need to keep an open mind on whether NASH resolution in every case will translate into fibrosis improvement. It's also worth focusing from a therapeutic perspective on the obvious fact that the vast majority of patients with NAFLD have steatosis and will not develop NASH. So I like to remind myself and companies to focus on the elements that are unique to NASH. Fat is clearly, or in most cases, necessary. It's clearly not sufficient. What are the drivers that convert plain fat to a NASH picture? And shouldn't we be really working extra hard to identify what those drivers are? Now, the good news is we know that fibrosis resolution and improvement is possible in NASH, and that's been taught to us by great bariatric surgery data, mostly from the group of Philippe Mathurin, his colleagues in Lille. This is their recent study in gastro. Showed, first of all, much like the dietary weight loss data from Eduardo Villar that I was peripherally involved in some years ago, that the more weight that's lost, the more likely you are to resolve NASH, and that's shown here in these three columns. In which you see a growing fraction of patients who resolve NASH based on whether they lost 5 to 10, or 10 kilograms per meter square weight. What happens to fibrosis during that 5-year interval based on biopsy? I think most of us know these data, and that is that over time, the fibrosis improves. A greater fraction at 5 years have modest or no fibrosis. What is interesting and subtle, and I need to talk to Philippe about this, if you look at that dark brown bar at the top of the column, that doesn't seem to change. And those are cirrhotic patients. So we need to be open-minded to the fact that the point of no return for fibrosis in NASH has not been characterized yet, and it could be different than Hep B or Hep C. We know very well that many cirrhotics, in fact, 2/3 more or less of cirrhotics who are treated effectively with antivirals for Hep B or Hep C will have improvement of fibrosis away from their cirrhotic state. We don't know if that's going to be true for NASH when we have effective therapies. Now, if we turn to combinations, and let me just give you the short end of the story is, I don't think anything's terribly promising yet to address specifically the task at hand that I was asked to address. These are the data that Rohit oversaw for combination therapy using selonsertib and simtuzumab from Gilead. There were a couple of points here. It was a very small trial. I'm not going to go through the data in detail. Efficacy looked like it occurred in retrospect in combination, and these data were used to justify a single drug trial for selonsertib, which failed, and then a phase 3 trial, which failed. And in retrospect, there was actually no phase 2 monotherapy data that supported its efficacy. So Gilead really tried to swing for the fences. They hit a big miss because they had really not done their homework in terms of a proper phase 2 trial, but the combination may or may not have been effective. There are, in fact, a lot of combination therapies that are being developed in the commercial space. This is from a nice review that you see the citation here. I'm not going to go through these in any detail because, to my view, none of them show particular promise. But what you can see is that they combine different components that we're well familiar with, whether it's ACC inhibition with an FXR agonist or whatever the drug du jour is for the company and what they have access to, and these are just listed here. Frankly, I can't even read it from here, so I can't tell you what's in them exactly. But if you look, one in particular, the Atlas trial, which Rohit can tell you much more about since he led it, this was using 3 different agents. That data was published very recently in Hepatology. I think this is one of the most creative uses of colorized data columns that I've ever seen. It takes some time to dig through it, that are depicting the different combinations and their different outcomes. These were small numbers of patients. To my view, there were, when you get to the point where you're trying to tease out differences in ballooning, differences in subcomponents of the NAFLD activity score, it's because you really haven't had any meaningful synergy at all. And so I think this really tells us that combination therapies are proving to be as challenging to design, implement, and show efficacy for as the monotherapies have been. More ongoing trials, and in particular, there are animal studies as well being done. What's been remarkable is, to my knowledge, a fair number of these combination trials have not been preceded by even animal studies that show any synergy at all. So it strikes me that if you invest the kind of effort and money, and of course the sacrifice on behalf of patients as well as providers, to conduct a combination trial, you ought to have pretty robust evidence of synergy in your preclinical models, as long as you believe those models are informative. So with that, I'll close and just emphasize some very simple points I've tried to make here. Combination therapy trials are accelerating because no single drugs have yet shown sufficient promise. Current approaches are empiric or strategic, and they are not based on either strong rationale or compelling preclinical data that underscore clear synergy. There's limited efficacy data to date, and the data that has been published in the public domain has been very, very disappointing. And therefore, I think it's safe to conclude that there are no front runners for effective combinations. But these, in fairness, are early days. Few combination trials have been completed. But if we establish a clear rationale and show some evidence of synergy in preclinical models, hopefully we'll accelerate the drug development pipeline. So with that, I'll close. Thanks, Zubair, and all of you again, and happy to take questions.
Thanks, Scott, as always, for this fantastic talk you just gave. We're going to go and actually start another panel discussion with a case. So I'll ask Steve Harrison, Ann Moore, Naeem Al-Khoury, Manal, Scott Isaacs, who's here we are, endocrinologist, who's going to also give an updated guideline. So they're going to discuss the second case. What I'm hoping to do is to just get that case finished by 12:15, so that we can actually review some of the guidelines and go from there. So please go ahead, guys. Thank you very much again.
Okay, I'm back with another case. We'll just jump right in. Anxious to get to this discussion to figure out what we're going to do with Tony. Tony did not get Dr. Al-Khoury's message that deep dish pizza is not part of the Mediterranean diet, unfortunately. So his weakness is pizza. Tony is a 60-year-old guy who comes into the clinic. He has the trifecta of type 2 diabetes, hypertension, and dyslipidemia. His BMI pre-COVID was 39, but if you look at that picture, I think maybe he has a few COVID pounds on board, so he's probably approaching the mid-40s at this point. So he has no significant alcohol consumption history. He presents with an elevated AST and ALT. ALT is 66, AST 76. His albumin is 3.5, so lower end of normal. So already I'm getting suspicious. I don't know about the panel. His platelet count is 170, so kind of lower end of normal there. And he had a FibroScan when he walked in the door of your clinic. And the FibroScan says his CAP is 360 and his KPA is 15.7. So what are we going to do with Tony right off the bat?
Can I interject a note of reality here? That's obviously James Gandolfini, who was the actor who played Tony Soprano. My first cousin was an assistant director on The Sopranos for many years, and Gandolfini died of an MI. So I think he may be anonymous in this, but I think everybody knows that he probably had NASH and coronary disease.
So we've already established Tony's cardiovascular risk.
Well, I think this brings up a point we often glance over, and that is, how did Tony get to this point? he's been laboring with diabetes and obesity and hypertension and dyslipidemia probably for many, many years, if not decades. My suspicion is he's had an elevated ALT for quite some time. I mean, now we see his AST greater than his ALT. So almost assuredly that's been elevated for a while. And, so and a platelet count that's probably trending downward. Maybe I'll ask Manal your thoughts, and Naeem's as well. Both of you guys see a ton of patients. How often does this present in your clinic where you're just blown away with how did you get to this point without being detected?
I'll take a first shot at this, but I think this is unfortunately a common presentation. In fact, we did a study when I was back at the Cleveland Clinic when we looked at patients presenting to be transplanted for NASH cirrhosis. And we wanted to see how many of them knew they had chronic liver disease before they had decompensation. And 68%, their first time they were told they have liver disease was when they presented with ascites, variceal bleeding, or encephalopathy. And this is even more advanced than Tony. I think Tony is interesting because he has many subtle features, as you discussed. His AST is higher than his ALT. His albumin is borderline low. His platelet count is definitely trending down. And I think for primary care physician looking at these labs, probably they won't be alarmed like us because nothing will be highlighted as low or high for them. And this is how these patients are missed. So unfortunately, I think this is common in my clinic.
I agree. It's also common in my clinic, and I'm at a tertiary referral center and that bell-shaped curve in my clinic is shifted far to the right. So for patients who would come, and I could confidently say this, Tony probably has advanced liver disease, independent of having to do a biopsy, especially with that dropping albumin and platelet count. But had he not even done that in the hands of a hepatologist at a tertiary care center, if such a patient were to get biopsied, there's a very high positive predictive value that he's going to have advanced hepatic fibrosis. And in our practice, if he had not fallen below the radar screen of other biochemical predictors of cirrhosis and underwent a biopsy, there'd be about a 20 to 25% chance that he had F3 or F4 disease.
Yeah, go ahead.
So he is very typical for someone that we would see in an endocrinology clinic as well. And I would just, I'd like to point out the fact that, he does appear to have significant liver disease, but he has significant cardiometabolic disease overall. And as was mentioned earlier, this is a very complicated patient that the general practitioner, the endocrinologist, is dealing with the diabetes, which is likely not well controlled, the hypertension, the dyslipidemia, but also, the cardiovascular risk. And so there's so much that needs to be addressed in a visit that's probably why someone like this got to this point, because they're focusing on so many other things and it's just a lot to handle. But trying to find some way of managing all these cardiometabolic issues, the common goal would be weight loss. And if he could lose significant weight, I think it could do more than anything else.
So there's a lot to unpack in what you just mentioned, actually. But Scott, I was going to actually let you make a comment there. You had mentioned that the MI story at the beginning. Now, we're talking about a different patient, obviously, but I think the data is clear that in patients with advanced liver disease, such as we think this gentleman has, that's where we see the advanced atherosclerotic coronary artery disease risk as well. And so really, to your point, it's a metabolic mess that we're dealing with. And to think that he's going to quit eating that deep dish pizza is probably a bit unrealistic, in my opinion, given the fact that we've given him 60 years to do it his way. And I'm sure somebody would hope along the way to have told him you need to probably lose a few pounds. Now, maybe that didn't happen, and maybe with just very emphatic, hashtag real talk kind of speak, you got to quit eating the deep dish, quit eating the bread, rice, pasta, pizza, potatoes, and maybe he'll have a change of heart. But we also know that there's never been a reunion for the Biggest Loser, right?
Yeah, they all gain the weight.
They all gain it back. So I don't know if you have any more comments on the CV risk from your perspective, Scott. based on the fibrosis?
Well, I think we know the obvious fact, which is that that's the most proximate cause of death until they're cirrhotic. So
Yeah.
the epidemiology is very, very clear. I would emphasize the weight loss. You know, I've tried to kind of line up what the boxes you want to check for any given therapy and what's the ideal therapy. The only one that checks all the boxes is weight loss. The only one. You know,
Can I challenge that though? One bit, and that is the slide you showed from Patrick shows that in the setting of F4 disease with 100 pounds of weight loss, they were really not moving the needle. Now, granted, there was only, I asked him the question that you wanted to ask, which was how many patients? There were 5.
Yeah.
That's small numbers that were followed over 5 years. But even if you look at the semaglutide data, where they lost a significant amount of weight, they resolved NASH in 59% of the cases, fibrosis didn't budge. And that was really driven by weight loss. So while we all believe that if you resolve the drivers of NASH, that in fact fibrosis should eventually improve, maybe in somebody like this, they need a little oomph, a little something extra.
Well, so that speaks to the differences in the mechanisms that you want for different stages of disease. And I think we probably all think about the metabolic targets, the inflammatory targets in inflammatory steatotic F1 through F3. You know, there comes a point with F4, there isn't that much fat. There may not be that much histologic inflammation, but there's a whole lot of fibrosis. And so the targets and the activity of therapies are probably going to have to be very different in those patients than who you'd be targeting in your, you know, in your larger group of F1 to F3 with inflammatory NASH.
Yeah, so thinking about drug therapy for this particular individual, we need to think a little bit broader than just managing the liver disease, ultimately. Can you go back one note? Because I think there's another case in point to be made from the FibroScan here.
Steve, can I ask you just a related question? Do you know of any, so for patients, say, with this sort of profile, it's easy to see that there's actually, you know, potential risk for cardiovascular sort of disease. But how about a patient that is earlier in terms of, and don't have all the metabolic? Do you have any serum biomarkers, not of fibrosis, liver fibrosis, of cardiovascular risk in patients with NAFLD?
You know, I think it's a great question. I guess I'm only aware of HSCRP, and I'm not even sure what that relational risk might be. And do you guys know HSCRP, what correlation there is to heart disease?
Well, there are two things that we need to sort of at least address. One is not just coronary artery disease, because that's one complication, but cardiovascular is also cardiomyopathy, of course, which is another common complication. There are actually plenty of biomarkers that are being developed in the cardiovascular sort of space that could be applicable to our patient population, because a lot of those patients have the same risk factors. So that you can actually look at some patient with fatty liver and say, you're at risk for liver disease, you're at risk for cardiovascular disease, you're at risk of both, without any. You know,
so I think it was Bob Gish that mentioned the ASCVD risk score that we can calculate. And I think to your point, there probably are some markers of HFpEF, you know, right-sided heart failure. I'm not aware of those offhand, but it's a good point. The FibroScan comment I was going to make, actually, Scott, you spearheaded that comment because you mentioned a lowering of liver fat as we progress to an F4, and clearly that's true. Some of our trials, we find the hard way that if we want to enroll a NASH cirrhotic, but we demand a certain amount of liver fat, that we're unlikely to enroll it as rapidly. And so absolutely that's true. In this particular case, the cap is 360.
I'm hanging on to hope that he's not cirrhotic yet.
Yeah. Well,
he has a lot of fat.
I think the hope is, well, it's minimal, but
Come on. Let me have a bone here.
You know, he is significantly overweight. We sometimes see a false positive cap in that setting, as well as a false positive KPA. But the totality of the data would suggest that he probably does have late F3, early F4 disease, I think. But
Dr. Alpuri, you wanted to add something?
Yeah, I mean, I actually want to ask the panel. So with this picture, meeting every component of metabolic syndrome with his age, with the AST being higher than ALT, borderline albumin, low platelets, stiffness of 15.7. Are you guys convinced that he has cirrhosis? Would you still need a liver biopsy? Let me add one more piece. Let's say you do an ultrasound and it says mildly nodular liver and your spleen is at 14 centimeters. Can we just...
And he's got a CT scan with collateral vessels and a large uncinate.
When can we just go with these NITs and say, this is a cirrhotic patient, I don't need to do a biopsy, I'm going to get him on a cirrhosis medicine if I have one available. Do we agree based on this, or?
Let's ask the panel.
I'll be honest with you. I don't know that I would have even done an NIT in this patient. I mean, in a specialist's hands, all of us can agree that this gentleman has advanced hepatic fibrosis, stage 3. I've never done a FIB-4 score or even had put value in a CAP score in this degree of obesity or the KPA for that matter. So I don't know that I would have done them in my practice. And as you said, Stephen, this guy needs kind of this oomph. And if he's gotten to the age of 60 as a diabetic, having heard probably the message over and over again about weight loss and not been effective, this is, and in the absence of other therapeutics that are approved short of clinical trials, this is somebody I'd actually talk to about bariatric surgery. Now, while I agree with you, if he was a well-established cirrhotic, that the ability to shift the needle on cirrhosis regression may not be feasible, the data does suggest in that Mathurin study that about nearly 50% of patients who had non-cirrhotic fibrosis did improve. And maybe we can minimize his cardiovascular morbidity and mortality. And if he was well compensated without a complication of portal hypertension or didn't have collaterals or esophageal varices, I would really find a wonderful bariatric surgeon to help me out.
So these are great comments.
During surgery anyway.
Yeah, the other thing is, which bariatric surgery procedure would you perform, knowing this isn't, I mean, there's questions as to whether or not he's already developed cirrhosis or he's on the fringes, right? So if you were to offer this guy a Roux-en-Y, for instance, and the surgeon would probably do a peek and shriek, right? He would cut him, see a shrunken nodular liver, and I got to convert to something else, like a sleeve. But I think that is an option. For the purposes of this discussion, let's keep it on drug development. And to answer the question about the liver biopsy, I think for now, if I saw this patient, we're in the middle of trying to develop good, effective drugs for this type of liver disease and for this stage of liver disease. And for that, currently, we need a liver biopsy. So now, where we are in 5 years, when we have drugs that are effective, I think that's a different conversation. But for today, this is exactly the kind of patient that we need in clinical trials to develop the drugs that will be effective down the road in these patients.
I mean, Tony definitely needs a heart-to-heart. For him, it's life, transplant, death. I mean, if he doesn't do something now. And it's a big job ahead for the provider who's taking care of him and for Tony himself. So that's where we're headed.
Based on what we have available today, anyone would recommend a GLP-1 agonist like a semaglutide at 2.4 milligram once a week to target obesity?
I think, Tony didn't know he had liver disease when he came into your office. And if you all think that's unusual for a cirrhotic to walk in your office and not know they had liver disease, you're sorely mistaken, at least in my clinic.
It's a great point. Norm, you had a comment. Question.
I've got a comment and a question, Norman Gittin. First of all, the commenters, obviously the reports today are extremely disappointing. We haven't even got to first base in the management of this condition. And look how many patients, how many thousands of patients have already been studied. But my question is, has any study ever correlated the results with weight loss? I haven't seen, when they talk about fat content and fibrosis content, I've never seen a study actually say, and in addition, the patient's weight went from A to B. Can anyone correct me on that particular observation? Steve?
Well, outside of a weight loss study.
No, not a weight loss study.
We don't really have
So the phase 3 trials, the answer is no. The phase 2 trials, there have been some studies with some weight loss, but it hasn't, the numbers aren't large enough on a post hoc analysis to really sort out that benefit. Those that have done it haven't shown that benefit. There have been a couple, but they really haven't panned out.
Isn't that a deficiency in all the studies that have been done? I mean, when one looks at the protocols, should that not be a factor, even in the phase 3 studies, correlation between weight at start and weight at the end?
Sure.
Okay, thank you.
Yeah. Michael.
Excellent session, and I agree with the sentiment. Nobody would take a patient with colon cancer or lung cancer and tell them to add fiber to their diet or stop smoking. At some point, you treat the disease, the effects of the disease. And I feel that somebody with Tony's constellation of metabolic consequences and his risk for mortality probably is higher as an early colon cancer or lung cancer, that they do need to be enrolled in clinical trials or considered for bariatric surgery. Our endocrinologist gets straight to it when they have somebody with BMI of 40 plus and metabolic and medically complicated obesity. So I think we probably undersell to our patients the need to skip through words to treat this and to get to pharmacotherapy and surgery.
Yeah, just one final comment. I think we have a few minutes to have this comment. So Naeem mentioned the idea of not doing a liver biopsy. What I mentioned in my talk earlier was a bit provocative in saying, can we use MR elastography to enroll a cohort of patients with cirrhosis and actually use that to show a benefit long term? So the data that Alina Allen and Mason have worked on in Rohit have shown that MRE can correlate to long-term outcome, right? So an MRE of 5 versus an MRE of 8, their rate of progression to decompensation can now be quantified. So if you could design a trial, and it's just a cohort, so you have a cohort of cirrhosis well-compensated patients that are biopsy proven, and you also get an MR elastography, but you do not use that MR elastography as an enrollment criteria. It's just part of the baseline set of data you get. The liver biopsy is the main inclusion criteria. But then you have another arm where you just enroll based on MR elastography. You follow those people out over time. You do the repeat liver biopsy in your other cohorts, and you're getting the MRE. And then in that one cohort, you're just doing MRE. There you can correlate directly within the same trial how the MRE is performing relative to biopsy, and then you have your outcome data. To me, that's how quickly we can get to MR elastography alone for a NASH cirrhotic trial. And you could rapidly get ahead of the non-cirrhotic trials with the non-invasive testing paradigm. Mason in the back.
Stephen, I want to echo what you just said. I want to pick your brain on something as well, especially the cirrhotics. So you just talked about MRE correlating with outcome, which is a great step. And I want to see it as a two ways on the freeway. We proved that the MRE is correlating with clinical events. And I think we need to do this data showing that MRE is showing correlation with regression. I'm just afraid we're not seeing this data so far. That when fibrosis is regressing, we have had trials that unfortunately they did not have biopsy, where transient elastography, maybe with anti-fibrotic drug, dropped by 25%, and the MRE did not drop yet. So I'm emphasizing what you said, and this talk was beautiful, but I'm slightly afraid that there is something or a piece of the puzzle missing with the MRE regression data that we still need to figure out. Rohit is not here anymore, but I think this is a great area of interest and great area of research that we need to discover with further research.
Yeah, there's more questions to come for sure, but let's make sure we have time to discuss the rest of this case.
So Stephen, I think you bring up an excellent point, and I'm going to put my neck out there and say, I think we're ready to do non-biopsy trials. And the reason is we consider the biopsy a surrogate. Now you said, well, the biomarkers are a surrogate of the surrogate. Well, I would say maybe not, because if the primary surrogate we're considering is insensitive, maybe the MRE is a comparable surrogate for the same outcome. And if we're measuring change in a surrogate over time, what difference does it make what the surrogate is? Because ultimately it'll translate into a correlation with the outcome. And so maybe we are ready, given where we are with MRE and Alina Allen's data, to measure change over time and correlate to the outcome as opposed to the histology in and of itself, because it has its own imperfections like any other surrogate to an outcome.
That's a good point.
And I think outside of a clinical trial, I'm not so sure I would biopsy this patient because it's not going to change my management. And for me to do an invasive test when it's not going to change anything I'm doing clinically, it sort of makes me.
Now, let me challenge that one bit.
Figured you would.
So again, as a hepatologist, I tend to, I'm the sole hepatologist for 24 GI docs in my practice. So I get sent the complicated cases. But thinking back to the seladelpar data, where we saw lots of interface hepatitis and plasma cells, how can we be sure this patient doesn't have coexistent liver disease, such as autoimmune hepatitis? And not that the liver biopsy would necessarily rule that out, but I would get a certain level of comfort that all I was dealing with was NASH in that particular setting. So I'm not saying you're wrong in doing that.
No, I think I would optimize his medical therapy, and if things weren't changing, I would consider a biopsy at that point, but it wouldn't be my go-to first time in the office. Does that?
Yep, I got it.
Does that work?
Okay,
let's get on to what are we going to do? The mission of the panel is to prevent a liver transplant in this patient. Do you choose to accept, and how are you going to do it? So sort of there's an array of choices here, and I think you could load Tony up with something from every category, whatever your flavor of the day is.
You could definitely do that. If that's our mission, then I accept, but there's one caveat. It's like the joke about the light bulb and the psychiatrist. So how many psychiatrists does it take to change a light bulb? And the answer is one, but the light bulb has to want to change. So, to some degree, the patient's going to have to be willing to listen to the intensive lifestyle management that we are going to bring to bear. And that's the first upper left-hand column with diet, exercise, weight loss, and potentially surgery.
Tony's afraid now, so he's on board.
He's all on board?
You scared him.
So maybe I'll ask our endocrinology colleague, how would you attempt to manage this patient, and how do you unpack this patient in your clinic?
So obviously the diet and the lifestyle are always going to be the cornerstone, the hallmarks of weight loss. But the reality is that this person is probably not going to lose any weight with diet and lifestyle. If you tell them to lose weight, they're not going to do it. So if you put them in an intensive lifestyle intervention and a structured weight loss program, you're talking about 3 to 5% weight loss. And this is not because of willpower. This is not because of really the lack of desire to lose weight, but it truly is biological. And you mentioned the Biggest Loser, and we haven't had a reunion, but they did have the Biggest Loser study where a number of contestants were monitored over a 6-year period, and most of them gained the weight back, and metabolic rate was significantly decreased even after they gained the weight back. And so and there's been other studies that have looked at hormones that regulate appetite, and they're also altered so that really the response to weight loss is weight regain, and that's truly biological. So I wouldn't waste a lot of time with him just telling him to lose weight, and I really want to emphasize the diet, but then really move on to pharmacologic therapy, and then I think bariatric surgery would be really optimal for him. And I think if you're, talking about a liver transplant, I think the bariatric surgery would be a lot less invasive.
We're preventing the liver transplant, not jumping to it.
So if I don't have access to clinical trials, I will be as aggressive as possible with this guy. And if he doesn't want bariatric surgery, I would get him on vitamin E based on the Chalasani data, although it's retrospective. And I try to get him on a GLP-1 agonist and induce as much weight loss as I can. Probably he had diabetes for 10, 15, 20 years. He's been told to lose weight with lifestyle by many doctors. So I'm not going to wait on this guy. I would get as aggressive as possible.
Let me ask Scott, as our fibrosis guru. So would you consider a statin in this patient for theoretical, not just hyperlipidemia benefit, but maybe some data suggesting a long-term fibrosis benefit, maybe a prevention of liver cancer benefit? What are your...
I think we'd all favor a statin, but I would have limited expectations of an antifibrotic or cancer prevention benefit. I wouldn't argue against using the drug, but I wouldn't say, well, we got him on an antifibrotic, now we're done. There's just no data that suggests that these are potent antifibrotics, even though in principle you're reducing cholesterol content both in stellate cells and in hepatocytes. That might be a good thing, but in reality the effect is really very, very modest.
So the flip side
of
that...
It will improve endothelial cell integrity also through KLF2, and there's a fair bit of data now that statins are beneficial for portal hemodynamics as well, but none of that is antifibrotic.
But what we can say is that it's safe to use it in this particular patient population.
And statins are also, not only are they safe, but, this is a patient with diabetes, and so he pretty much needs to be on a statin regardless. So the only reason he wouldn't be on one, from my perspective, is if he either didn't want to be on one or he had some sort of a, side effect or allergy, but he should already be on one.
So since we have an endocrinologist on the panel, do you have any problem with doing the most NASH-friendly regimen possible and putting him on metformin, pioglitazone, and GLP-1? Is that, I see, we have a few aggressive endocrinologists in the community, and we occasionally have a patient who comes in on that cocktail.
Yeah, I mean, that's a great cocktail, and even an SGLT2 on top of that. And I think some of the issues is coverage, especially if you want to have them on a high dose GLP-1 to lose weight, that can be more difficult than on the diabetes doses. But these are patients that even if they have good blood sugar control, we sometimes will add additional diabetes medications to help with weight loss.
So do we agree there may be hope for Tony?
There may be, but let's talk about what is the optimal, if we're developing a drug for this particular patient, what would that look like? What would be the optimal drug that would kind of cover the waterfront? Maybe it's a mechanism that you want to mention, maybe it's a combination. If you're sitting in the back room designing a therapy for Tony, what would it look like?
For me, it will be semaglutide with anti-fibrotic effects. That would be ideal because he's going to lose weight, he's going to improve his metabolic syndrome, it has a cardiovascular benefit. The only piece that's missing is the anti-fibrotic effect. And I would be uneasy with this guy who's most likely cirrhotic to get him on a medicine that didn't show me that. We have promising data with FGF21 now with Akira releasing their cirrhotic cohort. That was very eye-opening for me, and I'm very optimistic that we will see regression in fibrosis even in cirrhotics. So potentially these FGF21s, FGF19s, but something definitely with the proven anti-fibrotic effect that has positive metabolic effects.
Okay, so I'm going to challenge that. Every one of these I'm going to challenge. So if you're going to use a GLP-1 with a magical anti-fibrotic effect, understand that the AE profile of that is such that Michael showed this data at NASH-TAG. The majority of those people do not renew their prescriptions after 6 months. So they kind of fall off the wagon, so to speak. They're not going to continue to take these long term. I don't know, endocrinologist, do you know if that's true in your clinical practice to these patients that get put on a GLP-1? Does your clinical experience support what the literature says in reference to not renewing prescriptions? Do they tend to wane over time?
Yes, they do. I mean, I think that for the GLP-1s, I think people will stay on them longer because there is that perceived benefit that it's not just the weight, but the glucose. But with weight loss medications, anti-obesity drugs, the average is about 12 weeks before someone discontinues it. And we know that when most people stop the drugs, they gain the weight back. So how much good are we really doing by that temporary weight loss?
Manal, what do you think about induction therapy with one of those agents that maybe are injectable? They've shown some potency on fibrosis and on fat reduction, and then potentially switching them over to a therapy that is oral, maybe better tolerated, has more effects, positive impacts on atherogenic lipids and maybe glycemic control.
I agree that Tony here is going to need a dual effect, both on metabolic and anti-fibrotic, and the literature and the data with FGF19 having an induction effect of inducing both NASH resolution and fibrosis regression, and maybe some weight loss could be a consideration. Ultimately, other therapies like lanifibranor, which hit both endpoints, could be a consideration, although there's potential for slight weight gain. But I agree with Naeem that a combination approach of GLP-1 on the backbone of an additional compound, that whether it's other anti-metabolics such as SGLT2s or other therapies, PPARs that can give him an anti-fibrotic effect, or an independent anti-inflammatory, anti-fibrotic agent in combination with the GLP-1. But he's going to need more than less.
Scott, you're on the forefront of development of antifibrotics. Are there any oral, well-tolerated agents out there that show promise in this for Tony?
I actually think the most mature and promising are the integrin antagonists, which I talked about at NASH. They're driven by very solid mechanistic data. They look like they're well tolerated. They block TGF-beta activation. So I think for all those reasons, I'm most hopeful about one or more of the integrin antagonists.
Okay.
So is 2022 too optimistic?
That's way too optimistic. 23.
All right.
23.
So job security for all.
Well, the one exception of OCA is still fighting for approval, and I think the jury's still out there, but that might be a 22 if that were to be successful. But I think beyond obeticholic acid, the next one in line is probably 23.
So I think the other thing that's worthy of mention is that we can't prescribe the drugs that are available and see the patient back in 6 months, because it's a recipe for failure. And we have very busy clinics with limited access. So we have to figure out a way to coach these patients into successful lifestyle modifications. And that's not going to be done at a provider level, I don't think. I mean, we need some way of developing health coaches who are available when we're not. But it's got to be done, or we're going to have 1 million Tonys in the next 20 years.
I just want to go back to what you mentioned, Anne, about the endocrinologists using triple combination therapy to treat diabetes. So we did some work when I was in San Antonio with Dr. Ralph DiFronzo. He actually did that trial where he looked at patients that were randomized to triple combo with metformin, pioglitazone, and a GLP-1 versus standard of care, which is the sequential metformin, sulfonylurea, then insulin. And we have data now, although it was done a little bit too late in the study where we did fibroscans at the end. And we showed that these patients in the triple combo compared to standard of care, and they all started with similar ALT, AST, platelet count, that they have less advanced fibrosis, they have lower CAP score and lower ALT. I support this triple combination. If you listen to Dr. DiFronzo talks, he preaches that you do it from day one in a newly diagnosed type 2 diabetic, because you're going to save their beta cells and you're going to prevent them from going on insulin in a few years.
I mean, it's really almost too late. I hope not too late for Tony, but it might be. But if we caught these patients early and treated them appropriately, I mean, we see patients all the time coming into the office with hemoglobin A1Cs over 10. Their diabetes has never been well managed, and not to anyone's fault, but we need to get on top of that somehow.
So
I only use sulfonylureas when I have to, and it's usually because of the price.
We're about to wrap up here, but let me just ask each of the panelists, would you suggest to this patient, if he doesn't drink coffee, that he should drink coffee?
I'm on board with the coffee.
I am too.
I mean, the one thing I would suggest is he doesn't drink any alcohol, and I've been disappointed in many of my patients that say they don't drink, and even in the context of clinical trials, their PET will come back positive. So for Tony, I may do a PET test and just make sure.
But coffee, yeah.
And coffee is not salted.
Yeah.
Frappuccino, salted
what do you
caramel
think, coffee?
Frappuccino.
Well, that's the thing is that I think there's nothing wrong with black coffee, but the problem is what people put in the coffee. So got to be really clear about that.
No sodas.
I keep them away from the Bada Bing Club also because
There you go. Well, there's your answer. I
right.
think we're all in agreement
Yep.
to try to keep them off the transplant list.
Let's do it. All right, thanks, guys.
Appreciate it, guys.
All right, guys. Well, we only have two last lectures, and actually they're very important because Mayor Ranella, who's a professor of medicine at Northwestern Chicago, and actually is also the chair of our NASH task force. Is it called task force? Yeah, for AASLD, and it's going to chair the NAFLD guideline document for AASLD. Is going to review, update on the NAFLD guideline for hepatology and hepatology perspective, and then we'll have Scott Isaacs, who's from ACE, is going to come back and actually talk about the ACE guideline, which is for NAFLD, which is American Association for Endocrinology, Clinical Endocrinologist, after Mary. So we'll start with Mary. Thank you.
Thank you, Zobair, and thank you for really organizing a beautiful meeting. It's really lovely to see everybody. I've missed all of you. So what we're going to do, this is going to be very brief, so you guys can get to eating lunch and enjoying the day a little bit. So what I'm going to do is basically go through where we are with the new guidance. So AASLD has changed a little bit their approach to how they want the guidances and guidelines to be written. These are just the new parameters. So you're going to notice that there are some differences in the authors, which is on purpose because we're trying to recirculate people and have some new faces appear. So we are from now forward not to have any author on more than 2 consecutive guidances. The chair can't have any industry conflicts of interest. More than 50% of the writing group can't have industry conflicts of interest. And the COIs are going to be limited in the remainder. So the guidance document, in order to make it a little bit more nimble and quick to review, will be reviewed by independent committee, not through the practice guidelines committee. So hopefully that'll mean we'll have a guideline out for you or a guidance more quickly. So this is the writing group. In addition to myself, Rohit, Manal, Brent Tetri, Steve Caldwell, Shadab Siddiqui. From hepatology adult perspective, we have Sonia Caprio, that's pediatrician, also an endocrinologist, who will help provide that endocrinology perspective that's so critical to this disease. Stavra, who's really a wonderful addition, is going to be driving the pediatric section, and David Kleiner from pathology perspective. So just to first clarify, just like the 2018 document, which is a guidance, not a guideline, this is again going to be a guidance. And the difference is that it's not limited to, or it's not constrained by the grade criteria. It's not a formal systematic review, and this is how the other one was written. What we're going to do a little bit differently, it's going to be really a complete rewrite. It's going to be question-based format to guide the search. And we hope that this will end up providing a practical and actionable guidance document that can be used a little bit more easily, I think, in clinical practice than our 2018 guidance. It's going to feature, so updated data on natural history, because we now have some prospective data that's a little bit more robust. Modifiers of disease progression, which will include a bit more emphasis on some of the factors that Rohit mentioned: genetics, microbiome, and things like alpha-1 antitrypsin, and a little bit more of a focus on other endocrine type mediators. And then diagnostic biomarkers, we've had a tremendous amount of growth between the last guidance and currently, so there will be a much more robust section on diagnostic biomarkers, which will also be recapitulated and updated more regularly in an online live web-based document that we'll also plan on releasing shortly after the guidance is published. In addition, we will attempt to provide management recommendations based on some of the available agents that will be hopefully a bit more robust than the 2018 document. And of course, this is fueled by the fact we now have some data that we can put behind these recommendations. There will be very limited update on the completed phase 3 trials and emerging therapies. This is not really the focus of this document because it's really meant for clinical practice utilization. So Scott Isaacs is going to talk about the ACE ASLD combined guidance. It's actually a guideline. This is going to be a proper guideline with systematic review and grade for the management or assessment of fatty liver disease in diabetic patients. The writing group from a liver perspective will also include Zobair and myself. And this is the timeline's a bit more extended because it's a lot more involved to do this sort of a guidance or guideline. So right now we've completed the lit search and we're in the process of selecting the abstracts that'll go into the document. Publication strategy is going to be to make sure that we're harmonizing the statements that are in the ACE guideline with our own NASH or NAFLD guidance. We hope to be able to publish this in the January 22 issue of Hepatology. And then we hope to launch our web-based live document also in 2022, and then provide annual updates in Hepatology. So as far as an overview of the guideline development and what the timeline is, as far as my current plan, we have, of course, finalized the writing group. We've drafted an outline. It's been approved by the review committee. We're in the process of actually starting writing for some of the sections and others, still finalizing the clinically focused questions. And then by July, we hope to have a completed first draft. We will have the writing committee review this draft so that we can earlier rather than later pivot and make additions as needed. We're going to have approval of the guidance statements and hopefully submission of the first draft by the end of August to the review committee. In late fall, we hope to have the development of the more final document and then hopefully at least online publication, January 2022. So that's what I have, and I'll pass the torch over to Scott. And then Zobair, you want to say something first?
Thanks, Maro, for this wonderful and very quick to the point update. So we have Scott Isaacs, who's actually an endocrinologist from Atlanta. He's the medical director of Atlanta Endocrine Associate. He and Ken Kuzi are actually co-chairing the ACE guideline, guideline for NAFLD that Mauro and I are actually participating in. So we'll hear from Scott about what ACE is doing, which is actually quite exciting from my perspective. Thanks, Scott.
Okay, good. So I get to talk about the formal process of guideline development. And recently, ACE had strategic planning, like I'm sure a lot of you all have been involved with. And two of the big things that we found that were really important were guidelines, that ACE really wants to publish more guidelines, and also collaborations with other organizations. So this really, with a collaboration with AASLD, really kind of fits with our mission really nicely. And so this is a list of the members of the committee. You might recognize some of the names in here. And we tried to really find a diverse group of people that represent not just adult endocrinology, but hepatology and also pediatrics. And so we tried to have that balance on the committee. And we also tried to use the diversity and inclusion guidelines to have a good representation on the committee. So one of the first things we did was we developed a purpose for the guidelines. And this is supposed to be a practical guidelines for endocrinologists and for all practitioners who manage patients with cardiometabolic disease. And given the high prevalence of NAFLD in clinical endocrinology and primary care practice, and the paucity of guidelines that address the endocrine and cardiometabolic perspective, little guidance is available for frontline practitioners who care for patients with NAFLD, most of whom are undiagnosed. And so the purpose of this guideline is to provide endocrinologists and practitioners who care for patients with endocrine and cardiometabolic diseases with practical evidence-based recommendations for the diagnosis and management of fatty liver disease. And so the next thing we wanted to do was develop a scope, because you can't do everything. And so we had to limit what we were going to discuss. And the guideline will address key management questions and focuses on the endocrine and cardiometabolic aspects of prevention, diagnosis, treatment, long-term prognosis for the entire population of patients with NAFLD. And it's meant to be a practical patient-centered guideline for endocrinologists and practitioners. Just seeing these high-risk patients, we wanted to make sure that this is something that is practical and easy to use. We didn't want to have like an 80-page guideline, but we wanted to make it easy and simple. And outside the scope of this guideline is an in-depth review of the epidemiology in the general population or inclusion of controversial aspects of NAFLD, which is reserved for the liver specialist. And it also does not address interventions of a purely investigational nature, but only interventions available to the practicing clinician. So lifestyle intervention, bariatric surgery, weight loss and diabetes treatment agents, and any other agent with strong evidence from RCTs deemed as safe and effective, and any FDA-approved drug for the treatment of NASH, which is available at the time of publication. So this is just a broad outline of the topics. We considered questions for epidemiology, diagnosis, and treatment. And we use these questions to develop more detailed questions, which are used for our literature searches. And so the goals, we wanted to support the best practices in clinical decision-making in the field of endocrinology, specifically regarding patients with NAFLD, and to identify clinical questions that serve as the framework for the action statements that will include recommendations to optimize patient care. And we wanted to develop recommendations based on relevant evidence of the highest quality available for diagnosis and for management of NAFLD that answer the clinical questions that were developed by the task force. And so with the workflow, the development follows strict methodology and documentation of every step, and we use the National Academy of Medicine standards to minimize bias and to increase trustworthiness in the guidance. And the ACE CPG staff is supporting the writing task force and to ensure that the proper steps are taken at each stage. And the writing task force meets via Zoom, and we complete the assignments and communicate via email, and also we use shared documents. So support for CPG recommendations, we want to have actionable language, specifically to take or not take a specific action. We want to grade the recommendations to reflect the strength of the writing task force action statements, including risks or harms and benefits, specifically if the benefit of the recommended action outweighs the risks or burdens or vice versa. And we're going to grade the strength of evidence based on the quality of evidence in aggregate that supports a recommendation. And for the evidence, the studies are chosen by the writing task force that answer PICO questions, which I'll get to in a minute, and align with inclusion and exclusion criteria. And we want to have a succinct and narrative analysis that includes the assessment of evidence chosen for inclusion with a brief discussion of statistical significance, conclusions, strengths, weaknesses of the individual studies. So this is PICO. The PICO framework is the structure and focus of the clinical questions. And so the P stands for patient or problem. The I is the intervention or the exposure. The C is comparison or control, and O is the outcome. And the purpose of the PICO questions is to make it easier to identify search concepts and to appraise the results retrieved from database searches. And I will say that it's been a challenge with this, with fatty liver disease, to develop PICO questions. And we've made the agreement that there are certain questions that don't exactly fit into the PICO format. And we're just moving forward with that. So this is an overview of the guideline development. We started with the scoping and the purpose, and then we're doing the systematic literature searches with the inclusion and exclusion criteria and the keywords. And then we will review the evidence and appraise it. And so we do an abstract review and we create evidence base for each section of the document, and we complete evidence tables, and the methodologists at ACE help us with aggregating all the data into tables, and then we assign a quality of evidence grade. And then we'll make our recommendations. So we'll draft recommendation statements based on the supporting evidence. We'll assign strength of evidence based on the grade, assign preliminary recommendation grade, and research consensus on recommendations and grades. Reach consensus on recommendations and grades. And then we'll write the supporting text. So all the members of the task force will be writing some of the narrative to discuss the recommendations, and then we'll draft additional sections as needed. And then we'll revise the document, and then it'll go through the approval process. So for inclusion and exclusion criteria, these are derived from the PICO questions, and they'll support the framework of the clinical practice guideline, and it will provide a template for the design of systematic literature searches and serve as a filter for internal search results. And this will also help in selection of articles relevant to answer the guidelines clinical questions and inform conclusions and recommendations. So then the staff, with the oversight of chairs, will record the preliminary inclusion exclusion criteria, and then we will amend as the process develops, and which we expect to happen. So with the systematic literature searches, stage 1 are the literature searches limited to the randomized controlled trials, meta-analysis, and systematic reviews. And so these searches have been done, and we've performed supplementary searches and additional searches. It has been a challenge because there's so many articles, and so we've had to limit which journals we want to assess. And every time we do that, there's one more journal we want to add. So it's an ongoing process. And then stage 2 will be if we need additional observational studies to support our recommendations. And so once the initial pool of articles is identified and graded, each member of the task force reviews an assigned group of articles that against the preliminary inclusion-exclusion criteria that were developed during our very first teleconference. Each task force member enters a decision of include or exclude with a rationale, and then the staff collates the decisions. And that's about where we are right now in the process, finishing that up. So hopefully by the beginning of 2022, this will be practiced in endocrine practice and also with AASLD, and thank you very much.
Thank you very much, Scott. This was a great review of what AACE is doing. So let me just actually finish up because I'm between you guys and lunch. And the good news is that we are ahead. We're not behind. So what we heard today was some data on the global comprehensive burden of non-alcoholic fatty liver disease. We heard about NITs, both in the primary care setting, endocrinology setting, and subspecialty setting, how to identify high-risk patients with NASH. Heard about important endpoints, and then what would be the current and future treatment options with patients with non-alcoholic steatohepatitis. And we just heard and got some update about both AACD guidance document and ACE guideline document for NASH that hopefully will be available by next year. So that basically finishes our formal meeting. Let me just actually let you know that for the NASH advisor, for CLDF land advisors, we have a meeting right after lunch that starts at 1:15. This afternoon, we'll have the CLDF committees that are going to meet, and they also have scheduled meetings with the exchange, from an exchange perspective with industry. And then for those of us, we had 400 people, about 400 people who actually remained online virtually up to this point. So for those of you who are still there, please make sure that you actually join us tomorrow. Don't forget to register if you haven't registered. Just go to Chronic Liver Disease Foundation, oneword.org, and you can register for free because we have some fantastic presentations tomorrow as well. Now, make sure for those who actually have tablets to just leave the tablets on the desk. And finally, I just want to take a moment to recognize the CLDF Focus Medical Group. This has been an amazing team, truly an amazing team. I've been blown away by what they could do in the era of COVID to have this meeting put together so smoothly, not only to actually have in-person meeting here, but actually broadcast this to 1,000 individuals outside this country, actually, as well as the rest of the United States. This is going to be a norm for how CLDF is going to have the Liver Connect in the future. So with all of that, thank you very much to all our speakers for their fantastic presentations. I learned quite a bit today, and hopefully we'll see you this afternoon or tomorrow. Thank you.